Great. Good morning, everyone. Welcome to the 2025 MCT2D Collaborative-Wide Meeting. Very nice to see you all. My name's Jackie Rao, and I'm the Program Manager for MCT2D. So we have a really packed agenda today with a lot of good topics. I'm going to be kicking us off on some updates of what you can expect in the next year from MCT2D and how we're planning to support you in your practices. We're going to follow that up with an overview of this past year's A1C measure, so sharing about performance on that, and an introduction to the changes that we'll be making to the upcoming A1C measure based on what we learned from this initial round. And then we're going to have presentations from participating physician organizations on your efforts to improve A1C control within your practices. So looking forward to hearing from you on that. Then we're going to be having an introduction to our new performance measure on urine albumin creatinine ratio screening. And we'll be sharing some results from your practices on a survey that they've completed around their current processes related to this. We're going to then break for lunch, give you some time to network with your colleagues. And when we come back from lunch, Dr. Julie Wright will be leading a panel on urine albumin creatinine screening with some PO participants. And then our colleagues from the MShield CQI will be giving a presentation on health equity and data and how we can incorporate this into our dashboards to support quality improvement. I don't know. Yeah, I can stand closer to the mic. Is that better? Okay, I'll just stand really close. All right. Here's a bit of an overview of what we're going to be covering in the first section of the meeting today. So we're going to be talking about our performance measures and some timelines with those before we do a deeper dive into the performance measures in the later sections. We'll be talking about our meetings, so the upcoming fall meetings, a recap, a brief one of the spring regional meetings, and what we want to do for our collaborative-wide meeting next year. We'll give an update on our phone application that we've been working on developing, talk a bit about recruitment, review the updated PO scorecards, let you know what to expect from our dashboards for the next year, and then do an overview of our different initiatives and some support that we're providing for each of those. Oh, whoops. So related to the performance measures, all of you should have seen the baseline rates for the urine albumin creatinine ratio measure sent to you last Friday on the 30th. We're posting these in the admin portal so that you can easily access them. We've added a feature where you can now download and export that information if you want to share it. And one thing that we're doing differently with the measures this year is we're going to send the baseline rates directly to the practices too, hoping that that relieves some of the burden on you to distribute them. Those are also going to be available for practices via the admin portal. A number of your practices already have access to the portal. Over 100 practices, I think, do. We'll be encouraging them to sign up for an account if they don't have one. And then if they don't want to sign up, that's fine. You can share the baseline rates directly with them, but we'll be doing some practice level communication, both about the measure, how to access their baseline in a little bit. We also sent out the nephrology baseline rates earlier this week on Monday as well to the clinical champions, copying you all as the POs. We're close to finalizing our endocrinology performance measure that will be around billing codes for interpretation following the prescription of a CGM, and have that information to you. And then, like we just covered, the performance measures are going to be the primary topic of today's meeting. We're really looking forward to hearing from all of you on your experiences with these so far. And then looking ahead to the future, we're trying to think about how we can build equity into the performance measures too. And we'll touch on that a little bit later today as well via the MShield presentation. So to talk a bit about our meetings, just wanted to do a brief recap of our spring regional meetings. So we just wrapped these up in May, and we're really excited that we had the highest meeting rating ever for our regional meetings amongst 4 of our regions. So this really reflects that we're trying to give the clinical champions and the practices what's helpful to them and what they need from these meetings. So we've been having our endocrinologists and nephrologists attend the spring regional meetings and giving kind of specialized presentations there. And those have been really well received by your clinical champions. And what makes me really happy about these reviews, as you can see on the slide, like a lot of people said that the information that they got from the meetings, they are going to be able to like take back and directly implement into their practices. So happy that we're providing like this actionable information for them. And then looking ahead for the fall regional meeting, so calendar holds have been sent out for these. They'll be virtual like they were last year. They're taking place on October 22nd and November 13th with the same time as the spring meetings from 6 to 8 p.m. We've divided up the regions between those two dates, but like we did last year, we're flexible with that. If someone's unable to attend their assigned meeting, they're welcome to attend the other. And then at these meetings, the one content that we do have planned so far, we're going to be having the practices that are performing at over 90% on urine albumin creatinine ratio screening at baseline be presenting at these fall regional meetings so they can share a bit about their process and how they've been able to be so effective in that, in hopes to kind of give some information and guidance to other practices working to improve. And as always, we'll be having the PCPs attending the regional meetings, and then we will have separate specialty specific clinical champion meetings for the endocrinologist and the nephrologist that will be in November with the dates on those shared shortly. And then for these spring regional meetings, we do have all of the dates for these set. We haven't distributed the calendar holds for them because we're waiting until we have all of the venues confirmed, but keeping along that same schedule we've had in the past with them starting in early April and going through May. And so we hope to have this information on your calendars all shortly as well. So the last piece of meeting related information that I wanted to cover is we've been considering this as a team and we've been having these collaborative wide meetings in June, but looking ahead in 2026, we want to consider moving these to a different month. They're very, very close to the spring regional meetings, which ends up being administratively burdensome to our team. And we also thought it might be helpful and more beneficial to you all to have them at a different time of the year based on like different collaborative activities. So maybe like the start of the value-based reimbursement year or midway through like a performance cycle. So we do have a brief poll to understand like your preferences on that. These should work like we've done polls in the past. So if you're able to send the text that says MCT2D 945 to the number that's listed on the screen, which is 22333. And if you wouldn't mind answering when you would prefer to have the collaborative wide meeting. So we have a couple dates in summer, either July or August, which again gives some more space from the regional meetings, but is still like a little bit quieter and less busy of a time. We also thought September, right before the fall regional meetings, might be helpful as we enter into like a new value-based reimbursement year. And lastly, we have January as an option where, you know, start of a new year, kind of midway through a performance cycle. So interested what you all think on that. And I'll read it off again because I know it kind of is small on the screen. So if you can text MCT2D 945 to the number 22333, and then there's the different options: A for July, B for August, C for September, and D for January. And if I go to the next slide, hopefully we see some of the results coming in. Okay, awesome. So yeah, we'll give you a second or two more to answer this. This looks good. Looking like a lot of votes for September, August, which are, that's kind of what we were thinking as well. Right. Well, thanks all for your input on this. We'll get back to you within the next month or so with a specific date. Because again, whatever time we pick, we'll try to get this out ahead to you in advance so that you can plan for it and have it on your calendars well ahead of the meetings. Thanks everybody for your input. Okay. And to give an update, so we're getting close to being able to distribute our phone application. We're in the final stages of development for that. We've gone through the testing and are just making some edits so that it's easier for your practices to use. We had some challenges with getting the iOS version initially published, but we're past those and we're hoping to launch this by mid-July. We're really excited to get this out to you. We know a lot of your practices have asked for this and have wanted to be able to easily access MCT2D resources without having to like exit the EMR and be able to like pull them up on the phone. When we do launch it, we'll be sending out a specific newsletter to all the clinical champions about how to download it, how to use it, what features it has. One of the features that it has that I think is really great is you're going to be able to like text or email a resource to a patient, but it doesn't come from the clinician's number. It doesn't save anybody's number. It comes from like a generic kind of MCT2D one. So they're able to get those directly to patients without having to like share links or do things that are a little bit more difficult. So we're excited about getting that out to everyone. And then after we launch the initial version of it, we're going to continue iterating on this and adding new features. So we're hoping to add banner notifications to share updates, easy links to some of our value-based reimbursement surveys and forms so that it's even easier for your clinicians to do that. And then also being able to divide the app experience based on user type. So if someone's with a PO or a practice, they'll get kind of a different version of that. So more to come, and should have that app ready for everybody soon. And then wanted to touch base on recruitment because I know we've been getting some questions about this. So MCT2D is on an every other year recruitment cycle. So we recruited in early 2024 for a September 2024 start date. And then we'll be recruiting again in the first quarter of 2026 with PCP practices starting in September. We'll be recruiting both new POs and then new practices from existing and newly recruited POs. And like we've done in the past, we'll try to provide support to you as a PO around recruitment, where we'll host a webinar that's aimed at clinicians to give an overview of the MCT2D program and how we operate and what their responsibilities would be. We'll plan to host this in February 2026. And then we also, last time we hosted recruitment, included all of these handouts related to like the physician role in MCT2D, the practice role, the time commitment, the benefits to participation, the gold carding programs, all of that to help you support your practices and have them understand like the benefits in the program. And we will likely cap recruitment at 50 to 75 total practices. We implemented this cap last time and stayed under the 75. We brought on an additional 67. If we have more practices apply than that, we'll be considering factors like location, if they serve an underserved population, if they have a care manager on board, to kind of make the decision of which practices we'll have join. And then also wanted to take the opportunity to go over our updated PO scorecard with you for next year. This will look very similar to what we've done in the past. We really just have one new component on it that I'll go over. As a reminder, the score on the PO scorecard is tied to the $75,000 annual reward that Blue Cross Blue Shield rewards POs for performance in the collaborative, with the percentage of points that you earned tied to the percentage of that $75,000 that you received. So as in the past, one of the requirements for MCT2D is to have a certain percentage of the total attributed patients with type 2 diabetes in your physician organization represented by practices participating in MCT2D. To earn full points on this measure, you'd need to have 25% of your attributed type 2 diabetes population represented by MCT2D practices. And then POs who have 10 to 25% of this population represented will earn half of those points. We're almost ready on the update for this current scorecard. MDC is running those numbers, and we'll have them by the end of the month, and we'll have those to share with you. And then I know this is small and we'll be sending it out, and that we sent the slides this morning, but you'll get a more official copy of it later. But as I mentioned, many items on the scorecards are recurring ones that you'll have seen this year. So we have attendance on the PO monthly calls. We will be hosting the PO small group calls again, like we did in February and March of this year, where we grouped POs together with POs who had other similar characteristics like size, independent versus employed practices, to be able to share with each other how you're working with your practices, barriers you face, the additional support that you need. We received a lot of positive feedback on this opportunity to work and speak directly with your peers, and we'll be hosting these sessions again with different topics and different discussion questions. We also have attendance by the PO clinical champion and PO admin lead at the collaborative wide meeting as a recurring element of the scorecard as well. The only new PO scorecard requirement that we're adding is participation in one of our MCT2D work groups. So we have the steering committee, the EMR work group that's getting started and will have its first meeting next week, our health equity and advocacy committee, and our research committee that we're about to launch as well. So the new requirement is just that someone from the PO participate in one of these work groups and attend at least 75% of the meetings to earn the points associated with that. Finally, we have the PO learning community requirement as a component of the scorecard, which again, there's numerous ways that you can meet that, and we add more throughout the year, like presenting at one of our meetings, referring a patient, being interviewed for our MCT2D newsletter. And then lastly, we have the component related to performance on the scorecard. So, like we talked about on the PO calls this month, for next year, because of the timeline on the uACR measure, the performance measure that you're going to be rewarded on is related to uncontrolled A1C again. So, this is similar to what's on our current scorecard, where if your practices meet this metric, you earn the points associated with it as well. And then the additional component on that is signing into the MCT2D patient data dashboard twice in 2 separate quarters. And then moving on, wanted to give an update on the data dashboard updates that you'll see throughout the remainder of this year. So we're doing a large update at the end of this month where we're going to be adding in Medicaid claims into the registry. So Medicaid claims will provide us with medication and CGM utilization information for Medicaid patients and also add to the completeness of the A1C data for Medicaid patients. We're also going to be launching the next phase of the Dashboard 2.0 project with the inclusion of a trend report that will have run charts of all of the measures that are currently on our summary measures page, as well as a data completeness report that will show your PO and practices submission rates for biometric and laboratory measures. And at our PO calls that we're hosting this month in June, we're going to give you a full walkthrough and tutorial of how to use these new reports and features because I think they're really useful and that you'll get a lot out of them and want to make sure that you know what you're looking at. Then in September, we'll have the first incorporation of social determinants of health data, starting with race and ethnicity. We will also be flagging patients that have received care management by looking at the presence of care management codes in the claims. This was a request that one of the POs had for the dashboard. They thought it would be helpful to be able to see an opportunity for patients who aren't receiving care management and be able to know who is and isn't. And then in December, we're aiming to launch the next phase of our Dashboard 2.0 project that's currently slated to focus on the redesign of the patient list and patient profile pages. And then to give an update on our different initiatives. So as you all know, we've been working on prediabetes and being able to offer resources in this space. So in March and April, we did a deep dive as a team into some planning for this initiative and looking at the feedback that we've received on surveys from meetings from you, from the regional meetings to kind of understand what the needs were. In May 2025, we completed 2 focus groups where we have 40 members of MCT2D join between those two and kind of share their experiences with us. Now we're aiming in July 2025 to release our first set of tools related to prediabetes. So this is going to include like a screening guideline and criteria and diabetes prevention program coverage guides. These were 2 of the tools that at the fall regional meetings practices said that they needed the most and were most interested in around this. And then we're going to be beginning in August to really focus in on creating a patient-focused resource for prediabetes. So much like our Jumpstart site around low-carb diet, where it's a one-stop shop, has everything that they would need to know and do to start like a low-carb diet, we're hoping to do something similar for prediabetes as well. So we're planning to really focus in on that in August and then have additional tools released between October and November. And as far as like the clinician focus groups that we hosted around prediabetes, this is just a high level summary of some of the things that we heard. So, much like we had indicated initially, like on a survey from your practices last year, there's challenges within the DPP program. People feel like it's either too far, where the nearest program might be like an hour and a half away, too generic, too long. It's difficult for patients to kind of maintain that motivation and is difficult for accommodating work schedules or patients who have limited technology access. Practices also reported that there was more success with this with strong physician endorsement. So some of the feedback we heard there related to coverage and billing, it seems like people have a lot of questions on what is covered and how they can bill for this when supporting patients with prediabetes. So things like repeat A1C testing, dietitian counseling, medical nutrition therapy, diabetes education, weight management, care management. So we're hoping to build out from that initial tool that we're creating on DPP coverage to just give your practices more information on billing in general related to prediabetes care. And then the last one we're addressing through the program I just discussed, where there's more options needed for patient education. The practices want patients to have a menu of resources, approaches that fuel patient motivation, meet individualized needs, and are easy to integrate. And we're hoping to deliver that through the program that we mentioned. And finally, we are still open to patient interviews. We haven't had a lot of opportunities to speak with patients with prediabetes to understand their needs better. We've opened this up to the practices at the regional meetings and just wanted to remind everyone that through July 1st, we're still taking referrals for patients who may be able to speak to us about that experience. So if you can, please encourage your practices to refer patients by July 1st. And then another initiative I wanted to touch on. So, as part of a survey we did with your practices in May that you'll be hearing more about later in relation to urine albumin creatinine processes, we also asked about like what support they need with specialist partnerships. So, last year we had each of our endocrinology and nephrology practices partner with a primary care practice and choose an initiative that they wanted to work on that they felt could enhance coordination of care. At the spring regional meetings, you were able to review these posters with the endocrinology practices and the work that they did. So we went through and looked at all of the projects that the specialists and PCP practices completed. And in that survey, asked, like, of these projects, what would be the most helpful for your primary care practices and working with specialty practices? So the two things that came up were establishing best practices for identifying patients who require a specialist referral and recommended pre referral labs so that they can better support patients, and then enhancing care coordination by improving communication with the referring PCP following a specialist consultation. And then specifically for nephrology practices, they wanted visits focused on guideline directed prescribing of SGLT2. So these are some things that we've heard from your practices. We are going to take this back and think about as a team how we can support providing this information, particularly the first one around like the best practices for identifying and then those pre referral labs so that we can support your practices in that. And then for our next initiative, low carb diet, for as far as what's coming next. So we had our low carb diet workshop we hosted in May from the 12th to the 16th. We hosted this each morning to, account for people delivering clinical care, where we had a lecture series and then additional activities outside of class. So these included like tracking their carbohydrate intake, trying eating low carbohydrate for a day, working with our like patient chatbot on AI to kind of see how a conversation may go with a patient. The program provided, in general, a comprehensive overview of low carb diet interventions and strategies for practical implementation. We're going through the feedback from these meetings now, but we have gotten great feedback so far where all of the participants have felt that their increase in overall knowledge and confidence in low carb diets has increased, and more intensive implementation planning for afterwards. A lot of the participants are planning on starting group classes and providing additional staff education on low carbohydrate diet. So, due to the success of this, we right now are conducting like kind of program evaluation to kind of condense our lessons learned from that and see what we may want to change for the next session. But then moving forward, we're planning on hosting these low carbohydrate workshops likely twice per year with kind of a similar intro to low carb counseling in the spring and then a more advanced session in the fall. For the advanced session, we're going to reach out to attendees to vote on topics that they're most interested in learning about, but this might be like supporting patients who are doing low carb diet and who are on a CGM. And then we're also planning to host a clinician focused event for dietitians, as there were many requests from dietitians specifically who wanted to join the workshop. And we said, this might not be like the right level of education for you considering like their background in it, but we're planning on offering support directly to dietitians as well. And then finally, one of our content experts within MCT2D, Dr. Dina Grausda, she's developed a self-guided 16-week program that supports patients who are following a very low-carb meal plan, so less than 50 grams of carbs per day. It was an online program that has like 3 to 5 minute videos for each of the 16 weeks, handouts, recipes, tips, and then patients were tracking their weight and carb intake. We are planning to adapt a version of Low Carb Journey for MCT2D to share with the collaborative for practices who are interested in doing this work. And then related to our CGM initiative, we're very excited that we've been able to expand our user experience program to include Dexcom as well. So previously we had the opportunity for practices to try an Abbott CGM, and now we've expanded that to both. Each clinician will be able to participate once per brand, and then we do have that linked with a physician level VBR opportunity where after they submit a testimonial, they get credit for that. So excited to be able to offer that for Dexcom as well. And then also related to CGM, on the survey that I've referenced earlier, and that you heard at the regional meetings as well, many practices do not have a process in place for getting CGM reports to providers before a patient visit. As you can see in this graph, almost 40% of practices never get a report to a provider prior to seeing patients, and an additional 35% do only some of the time. And of those practices that reported that they only do it none or some of the times, 43% of those were interested in participating in a quality improvement activity to understand their processes and to get support in being able to get those reports to providers. So, what we're going to be doing is reaching out to those 40 practices who were interested in that and were interested in doing a QI project to do a more of a deep dive and understand like their specific needs and gaps in their processes around CGM. And then we're going to be providing individualized practice level support where we kind of go into their practice, help them troubleshoot, help them get set up with more of these practical elements of getting an account, getting the patient data to them. We're going to be piloting this with 3 to 4 sites, and then we'll be expanding it more broadly and opening it up to more, and hopefully bringing up those numbers where providers are getting reports well ahead of their patient visit up a bit. With that, I'm going to hand over these last few slides of this section to our CGM expert, Heidi, who has a few updates for you. And then Heidi is going to then lead into our session around A1C control measure. So thank you, Heidi.
So, oh, going the wrong way. So real quick, wanted to give you some freestyle Abbott updates. So hopefully you all know that the Libre 2 and 3 sensors will be discontinued as of September. So hopefully not a newsflash. But what I did want to let you know is we've been hearing that they're actually going to start ramping down production of those. So patients might start to experience shortages. So take home is start switching patients now so you don't get to the point that they are out of a sensor and you have to send a new prescription. The other thing, if you have the ability and maybe the POs that are here can help your practices out, is generating a list of those with active prescriptions for Libres 2 and Libre 3 sensors, and then try to have some sort of outreach. I don't know how that would be operationalized, but I'm going to be looking into that in my clinic so we can try to get everybody switched out. Patients are receiving active solicitation from their DMEs to switch, so you might be getting calls too. But I think if we all work as a team, there'll be no interruption in care. The other thing I wanted to share with you, and I was able to share this at regional meetings towards the end of our regional meetings, but as of the end of April, Abbott has a new app. So it's called Libre by Abbott. And the cool thing about it is it's a single app for all the sensors. So when you have a patient and you tell them about it, you want them to use this app when they're applying a new sensor. So have them download the app on their phone, and then when they get ready to put their new sensor on, it'll link and everything, password, user name, all of that stays the same, and the ability to share data with you stays the same as well. And I put a little picture so you can describe. My patients always like to know what it is. So a little black box, yellow butterfly should be easy to remember. If you have order panels, oops, nope, that's the next update. Sorry, getting ahead of myself. So now moving on to Dexcom. So sometime this summer, not sure when, the Dexcom G7 15-day sensor will be released. And so now patients will only need 2 sensors a month, and it will require a new prescription. So if they're currently on G7 10-day, the original, you're going to need to send in a new prescription for that 15-day. But again, we're only told late second quarter, so a second half. So we'll see. If you have order sets, this is what I was going to say, you will need to update that because then you can pick from another sensor. All right, so like Jackie mentioned, for the remainder of the meeting, we're going to be talking about our performance measures. And so I'm going to be starting off with our A1C measure. So first, wanted to orient you to kind of our thought process in picking our performance measures. And so for last year and this upcoming year, we find it's really important to align performance metrics with HEDIS, which allows meaningful yet manageable quality improvement work. And so this alignment is also very much supported by our funder, Blue Cross Blue Shield of Michigan. And then finally, our measures must be supported by our data. So which data do we have the most complete and reliable data? A1C. I'm sure you all recognize everything on the screen here, but the HEDIS metric for glycemic status is defined by the percentage of members 18 to 75 with diabetes, so that includes type 1 and type 2, whose most recent glycemic status, which can either be A1C or GMI, meets these percentages listed in the box here. So for commercial, the 95th percentile is defined as 70% or more. And then for Medicare, a different A1C, so they need to be at or below 9%, the 95th percentile is 87%. So our current measure right now, measure population is patients with type 2 diabetes, so small little deviation from HEDIS, with a type 2 diabetes diagnosis, and they have Blue Cross Blue Shield of Michigan commercial or BCN commercial, or the also corresponding Medicare Advantage plans. We targeted the same HEDIS glycemic measures as defined by 95th percentile, so keeping it simple. So what did we do this year? We formed aggregate groups, and we did this for practices within a PO who had less than 100 patients. And so we were hoping this would allow people to work together and have more patients in their denominator. The other thing we did is we locked the population. So that allowed for it to stay stable, so no patients were added. But then the other thing is if people, prescribers left the practice or there were mergers, those patients actually dropped out of the denominator, so the patient panel got smaller. The other thing we did was for practices that many of you were already meeting or exceeding these measures. And so we asked for a little bit more. We asked that you fill out a form for 5 patients with uncontrolled A1Cs and give us an idea of your challenges and your process for helping these patients. So to get an idea of where we are at as of today, and this is data through the end of February, final reporting will be given out mid-July. But as you can see on the right, the orange bar, 86% of commercial patients are meeting the metric of less than 8%, which is a 2% improvement from baseline. So congratulations. Looking at the blue bar, which represents our Medicare patients, 97% of those patients are meeting the metric of 9% or less A1C, and this is a 1% improvement from baseline. Just wanted to give a shout out to a couple of practices here. So 2 practices listed here have the highest commercial and Medicare rate. So if this is one of your practices, you can wave your hand as the PO representation, but just want to say congratulations. Yay! Would have liked to have had a bow, but I didn't have time to get little awards. But then we also wanted to recognize the practices that most improved. And so as you can see here, when it comes to Medicare, Huron Valley Physician Associates had a near 9% improvement. So that is fabulous. And then Munson in commercial and Medicare saw improvements as well. So wanted to give Munson a shout out. All right, so now we're going to go back to those A1C forms. So again, practices that were meeting or exceeding our measure were asked to fill out these forms, about 5 patients with uncontrolled A1Cs at baseline. So this data on the screen represents 703 forms that we have received to date. We analyzed this, and good news, nearly 44% actually have at goal A1Cs as defined by HEDIS. So this is fantastic. The form then went on to ask, so they improved, how? What was the reason? So we actually offered a pre-selected list that they could choose all that apply. So that's why you see counts here and not percentages. But adding new med was the highest reason. Then supporting patients with lifestyle improvements was next. And then finally, dose optimization were reasons that we saw improved A1Cs. Let's go. Okay. So for the remaining patients that did continue to have uncontrolled A1C, we asked about the biggest challenge. And this was a pick only one answer. So the most common reason was engagement. and motivation. So I know I see this in practice every day, and I try to retool my toolbox each day with patients and try to figure out how to move that needle. Next, we had other category. And so when we looked at those written in answers, things that we saw were due to medication side effects, medication shortage, which hopefully that won't be around anymore, and then comorbidities. All right, so just as a reminder, if you haven't completed, if you're one of those high performing sites and you haven't completed your 5 forms, here's the link to that form. I do want to point out that patients that you're submitting these forms for have to be on that original baseline list. So if you submit a form with a patient who has an A1C, but they are not on that original list, you're going to be getting a message from us to redo it. So it needs to be from that original baseline list. You can track your progress of your practice on the admin portal. So you can see how many forms you have left. And then reminder, this is due July 1st. So a couple more weeks. If you haven't, if you're delinquent like I am, you got an email on Monday saying, hey, you got to get this done. So we're going to be sending those out weekly. The other thing I forgot to say about the admin portal is we will be updating that every Monday. So if you turn it in and you check it on Thursday and it's not there, wait till the following Monday and you should see your credit given. The other thing to note is, as in a couple slides, we're going to be talking about the upcoming measure. This A1C form will remain in current, but will not be moving ahead for the continued A1C measure. All right, so before we talk about the upcoming change, I wanted to kind of revisit the performance measure timeline. So this is a little dry, I'm gonna try to make it fun. But as you can see, dark blue line, baseline period. So we looked at any patient that had an A1C in this time frame that started on June 1st, 2023. So that was the beginning. And that ran through May 31st, 2024. And if a patient had an A1C, was attributed to your list, that was kind of your locked list. And so you see that little lock symbol there, that was what you've been working for this year's performance period. If a patient was in your denominator list, if the patient wasn't seen or did not have another A1C, the last A1C that might have been from that baseline period would be counted for performance. So hopefully that makes sense. And so then that entire timeline then of beginning of baseline to the end of performance, we're calling the measurement period. So what did we learn from this year? We learned lots of things. So practice aggregation, while we thought it was a great idea, led to some confusion amongst participants. It altered the locus of control, which not everybody loves because it forced practices to work together. And we all know how everybody loves to do group work in this room. So had some challenges there. The other thing was performance became a little difficult to track due to mergers, due to closures of clinics, due to prescribers moving practices. So this became a little bit of an administrative nightmare. The other thing, the other impact of the practice shuffling was, like I mentioned earlier, that reduction in the denominator. Because let's say a prescriber left a practice, that whole patient panel dropped out of that practice's denominator and did not get added to the new one. So these reductions, again, I already mentioned, so departures, retirement, but then there was also attribution issues. I did want to note, Lauren's going to go over this more when she's talking about the upcoming uACR. We will be including provider level attribution at baseline. Okay, so as we move forward, we are going to be continuing our A1C performance measures with just a couple of changes. So we're going to refer to this kind of continued A1C measure as A1C year 2 performance measure. The measure population, as you can see on the screen, remains the exact same. So type 2 diabetes, Blue Cross, BCN, Medicare Advantage, all that good stuff. The target rates, we're also keeping the same with HEDIS. So same 70% for commercial, 87% for Medicare. And so then we get to the changes. There's 2. You may not be surprised, but we are getting rid of the aggregate groups. So no more aggregate groups. Each practice will be responsible for their independent performance moving forward. The other change is that we're not going to lock that population. So if you can see, oops, nope, not there. Next slide. We're going to be allowing the population to kind of ebb and flow, and we'll be locking it in the last 2 months, which I have lots of graphics coming up that'll hopefully make more sense. Okay, so here's that graphic. So you can see lines, colors, pretty much the same. First change you might note is that baseline period, the dark blue line, is now going to be referred to as look back period. So it's the same thing as that baseline in that it's still 12 months and it's the 12 months preceding the performance measure. Like I already alluded to, we're allowing the population to ebb and flow until February 28th of 2026. And that's when you'll see the lock appear. Because for those last 2 months of the performance measure, we're going to lock in that population. And we're going to keep talking about this a little bit more. But then the final thing about the graphic, that yellow line, same thing. That's from the start of the look back to the end of the performance is the measurement period. So you might wonder why we're making this change. And we really wanted to allow for these changes that I talked about that kind of made it a little bit difficult with a locked population. So we want, we acknowledge that prescribers are going to move practices. People are going to retire. Practices are going to merge. And so we want to allow for that patient base to stay steady. But at the same time, we recognize that it takes a little bit of time to get patients in. And so we don't want to limit practices and have them held accountable for getting A1Cs. And so that's why we're locking it the last 2 months, so that we're acknowledging the fact that it takes a little bit to get patients in. All right, so how are you going to know your denominator? Practices should use their MCT2D data dashboard to view attributed patients, and so that's going to be your current performance denominator. We will not be providing baseline patient list. We will be providing baseline performance reports, so just a little distinction there. And then once that denominator is locked, we're also not going to be providing any lists, because keep in mind our data lags, so we won't get the new data till after that April 28th date. Okay, so that was a lot of information to digest. Hopefully it makes sense. But just to kind of summarize this, our upcoming measure is going to start, it has that look back period starting in July, and then that performance measure is going to go all the way to April 30th, 2026. And those are the patients that have, if they have one A1C and they're attributed to your clinic, they're included. The most recent A1C will always be used for performance. And then just a little note, keep in mind, if a patient isn't seen during the performance period, the A1C from that look back period is what's going to count towards your performance. All right. So as we mentioned before, we asked a little bit more of our practices that were already meeting or exceeding our performance metric. And so another request that we made was that they present at this meeting and share the ways that they're doing things to have these great numbers. And so I'm very excited to introduce our presenters. So as I call your name, if you want to come up here and take a seat at our table, Haley Kinsley. Is Haley here? Yes. Oh, Chelsea Hochschild, Ashley Sumara, Malia Boss, and Alex Tracy.
All right, and introduce yourself as you ask your question, gentlemen here. Sorry. Please do not move microphone. I did. It was fine. Okay, I'm going to bring this over so you can ask in the microphone.
or I'm where this is going to be loud. So you can submit a GMI, I guess. I don't know how to do that. That's all.
Jackie, Jake, and Heidi, do we have a good answer to how to use GMI for performance at this point? And if the answer is no, we'll work on it.
Performance in HEDIS specifically?
Us.
With us, so for the performance of A1C, GMI is not currently being counted simply because we don't have CGM data being incorporated into the database at this point in time. That is something that we're hoping to add. We're actually working to figure out what the exact link codes are without getting into the weeds. There's some data complexity there. However, Blue Cross is starting the process of trying to incorporate GMI for the purposes of HEDIS tracking, which will help drive forward that data collection. So that's something that we're seeing start to become more mainstream. But as it does, we'll start to add it into our database. Yeah. It would have to come through the PPQC QMI use case. Yeah. Yeah, so that would be through the MyHIN data use case that you guys are sending. So basically the EMR data that's being sent for HEDIS closure, it has to come through that from the PO. It will never come directly from Abbott and Dexcom. No. At least probably not in our lifetimes. Yeah. Which, so there's no uncontrolled forms for the year 2. Yep. 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 No more forms. Yeah.
Where are we finding our list of diabetes prevention program? I'm going to answer this question and then someone tell me if I'm wrong. The state of Michigan still provides a really excellent website with a list of all of the I see some, yes, I am correct. So we will share that website. So I think we're lucky just because our state Department of Health is filling that gap. But yes, things that were present on the CDC website are now missing. Yes. Yeah, so we've been thinking about this question a lot when it relates to prediabetes, which is that there's not going to be a one-size-fits-all option for people to prevent diabetes. For some people, obesity and adiposopathy or inflammation due to fat cells is a driver of eventual type 2 diabetes and other metabolic diseases. But for other patients, you see these folks who are extremely slender and have very little abdominal fat. And so this idea that type 2 diabetes is not like a homogeneous disease. So in addition to diabetes prevention program, there are some other resources that we've identified. And, you know, for some of those patients, I think metformin is a very reasonable prediabetes treatment strategy. We haven't yet come up with any kind of a performance measure. We're not tracking or like requesting that every patient be sent to the diabetes prevention program. And I think I just want to keep your thought in mind. If we were to do some sort of feedback to you, would it only be for patients who have obesity and prediabetes, that then maybe we measure referrals to the diabetes prevention program? But I absolutely agree with you. And if people have other suggestions as to what the other resources might be that you'd like to see us identify, that would be helpful. Is that a helpful answer? Okay. Any other questions? Yeah.
Just maybe an opportunity when downloading the data from the dashboard, it would be nice to see the date that the A1C value is representing. So that way, especially when you're having not a locked population, it will, you know, like, do you anticipate those patients are going to be coming in soon towards the end of the measurement period?
It's coming. That was the easiest question ever.
what I appreciate of this time being together in a room is that, you know, we hear comments and feedback, but we always take it back and change. And we have this incredibly hardworking team kind of trying to get a minimal working product out to you and then make it better every year. I think I'm going to put the mic back. And then if it's okay with you, any other questions we can answer during the next break and we'll move on.
Oh, go ahead. Yeah, okay. Question on the GMI. So the PIPS accepts the GMI via supplemental teaching codes and we get credit. Is that not to be reflective in the portal?
GMI is not going to be reflective in the portal at this point in time because we do not have the clinical indicator codes. This is a difficult question to answer without getting incredibly technical, so I'm going to try my best. So there are specific codes that give the data an identifier that come through, and because CPT is typically just if something happened rather than the value associated with it, that doesn't tell us the actual value, and so we need the LOINC code, which is something that we're mapping through another acronym called PPQC. And then that enables us to bring that in. So as soon as that starts being reported, and those link codes actually just launched within the last couple of years, like a year and a half, we'll be able to incorporate them. So there will be a little bit of time until then, but ideally that A1C indicator from CGMs will be incorporated, but not right this minute, just because of technical. Through the blues because of, yeah, unfortunately.
Great medium technical answer. Heidi, I just want to appreciate you. You got the most technical of our slides, but we'll go ahead and move on.
Oh geez.
Do it.
Teamwork. Do you guys feel vulnerable? You gotta be a little close to it.
All right. This is a bad sign that we're going first, and I put the wrong date on the slide if you didn't notice, so ignore that part. I'm Susie Knopf with MCCO, Population Health Manager, so kind of the admin support, but work on the population health side.
My name is Haley Kinsey, and I'm the nurse care manager that helps coordinate the program with the participating practices.
So what we wanted to do was share our A1C process. This is not rocket science at all. Yeah, you can, oh, you got it. So our goal obviously is to have patients with their A1C under control, and I can't stand in the right spot and do this. I'm obviously not experienced at this either. So we look at all patients, all payers. This is not just type 2 diabetes, it's type 1 and type 2. It's Medicare, Medicaid, commercial, everything at this point when we're looking at our goals. But we do use the HEDIS CLQI targets from Blue Cross when we set our goal for at least the 75th percentile for that patient for A1C control. On my side, we're working with all practices individually, and then Haley will step in and she'll tell you a little bit about what the care team does. So go ahead. Thanks. So we have a population health team. We call them PCMH coaches, and every primary care practice has a PCMH coach that meets with practices almost monthly. And that's why I say, I think not rocket science, but consistent discussions with practices is what really helps. All of our practices are on Epic, and then that Epic data is translated into a Tableau dashboard. We track and trend. We compare against each practice and providers so that it's very transparent, and I think that makes a big difference. And then we use a diabetes registry. So the initial data from our Tableau dashboard is just patients who have been seen in the calendar year, which isn't the greatest look for how well you're doing. Our registry looks at entire populations, so it goes back at least 3 years to take a look at patients with a diagnosis of diabetes. And then from there, not just sharing the data, but the population health team either runs lists or teaches the practice to run lists themselves so that we target specifically every month patients with no A1C or no office visit in the last 365 days. So I think that's our biggest thing, and practices work that very consistently and regularly. And because they do that, the lists are not overwhelming, even for our residency programs with 30 providers. So it is reasonable for everyone to do that, and works pretty well. Go ahead. Just quick glimpse at, we did hit our target of A1Cs in, this is just a view specifically of 4 MCT2D practices. Just sharing that overall, we also as an entire organization hit the goal of A1Cs in control. Haley's turn.
All right, and then for our practices involved, most of them have chronic care management services. So they have the nurse care manager embedded in their office who will meet with their patients, do the initial assessment, kind of see where the patient is, provide that education, and then follow up. We did come up with a standardized care plan within Epic. We're still working to get everybody on board with that, but we do have it available to kind of make the documentation easier when we see these patients. And then we do have the standing orders to enroll patients into chronic care management services. So the A1C over 8 or newly diagnosed, which we can use the list that Susie was talking about to find those patients and reach out to them. And then a big part of my role is just educating and making the practices aware of the resources available through MCT2D. I send out emails roughly every month or when an update comes of the handouts available, and then just make sure that if they need copies, I get those for them so that way patients and the practices can use those. Most of our practices enjoy all of the handouts, so I'm making copies pretty regularly. And then we do have the collaboration with pharmacy, endocrinology, and then our diabetes center. And so this year, for BBR, we did work on an endocrinology referral guide, just kind of providing the primary care practices with tips and hints on what labs should be done prior to reaching out and placing a referral.
And again, next steps are pretty easy. The only thing I wanted to point out is that we are in the early points of using Health Focus as a population health platform. And I know there are a number of physician organizations already doing that and seeing the benefit of Health Focus and data tracking, but that is one of our other new steps. So thanks.
Good morning, everybody. I'm Chelsea Haaschild with Integrated Health Partners, and I am the administrative lead on MCT2D. And then with me is Kathy Golomsky, and she is the clinical champion for our physician organization and also the manager of quality improvement for our PO. So our goals and interventions really focus on exposure. So exposing as many people to the resources and the pillars that we're all working with within this collaboration, education, and then just collaborating with all different roles within a practice, from MAs, practice managers, physicians, etc. So we have only 2 PCP practices, so no nephrology practices in MCT2D right now. But we had 2 that at the beginning were already meeting the HEDIS performance measures, so they were already doing quite well. So our goal was just to maintain that. So the how behind that is, like the previous speaker said, we do have practice coaches. So they're meeting with the practices regularly and reviewing data. This is A1C control has been a HEDIS measure for a really long time. So as far as that goes, nothing really new. But what is new is all of the really rich materials and resources that MCT2D has. So again, with the exposure, just trying to bring the website up, let everybody know that you don't have to be in the collaborative in order to have access to those resources. We send out routine communications. We are updating, every MDC refresh. We are pulling those reports, looking at them, providing targeted patient lists to the patients for patients who are not under control. We also host various meetings throughout the year. Some of them are targeted just for care managers. Some of them are just for physicians, and then some are for like a physician team that includes a care manager, a physician, and a practice manager. And so we are, bringing back all of the learnings and ideas and best practices and sharing those with all practices, whether they're in MCT2D or not. We also had a clinical champion write a newsletter that goes out bi-monthly to our physicians on, how to improve A1C. And then she also wrote an article that is in Scene magazine. So we're in Battle Creek. That's a local community magazine. So just trying to even get the exposure out to the, larger community. She presented at a care management collaborative on some of the ways that care managers specifically can utilize data and best practices to help improve A1C for patients with type 2 diabetes. The other thing is that, we're really pushing the clinical champions to spread this among other providers. So, the clinical champions that attend the regional meetings and have all of the requirements for the the participation-based activities, they get a lot of exposure, but some of the practices that have a lot of providers are not getting that information. So we're meeting with them and asking them what they're doing to include other providers and spread this information. And I will tell you that, we have had some changes with clinical champions over the past in both of our practices. And I'm sure that everything that I've said so far is, again, it's not groundbreaking. You're probably already doing this too. But I've seen an incredible difference between the clinical champions that were maybe just sort of elected for this versus those that have a true passion for treating diabetes, and, their level of engagement and motivation and what they're willing to do and think outside of the box is like night and day difference from somebody who, just was sort of picked for this because they needed a clinical champion. So I would say that if you, take away nothing else from what we have to say, look for those gems that really care about this program and what you're trying to achieve.
Okay. Oh.
Maybe if I go down like this a little bit, I'll just kind of do a little squat here. Probably good exercise as well. All right. So I'm Kathy Glomsky. I'm the clinical champion for this for RPO. And also, as Chelsea mentioned, I lead the QI team. And I'm just going to go over a little bit of the outcome. So obviously, we want to at least be able to maintain and potentially improve our performance. So we were successful at baseline. We weren't quite as overachieving as some of the practices that Heidi mentioned. But our baselines, we were between 90 and 96% compliance with A1C, depending on the practice and the population. So pretty good. The current dashboard for MDC with data through the end of February, we're at 90 to 97%. So we did maintain and improve a little bit. So we were very, very happy about that. I did look up, thankfully there wasn't a long list of our uncontrolled patients, but I did look up, and 9 of those patients did achieve the target that were previously uncontrolled from the baseline, and their average A1C was 7.2, so pretty good. Happy about that. And then, like Chelsea mentioned, we were able to successfully navigate a change in clinical champion. So in one practice, we had a super motivated, engaged clinical champion, and then changed to a maybe a little bit more hands-off clinical champion. But I think what we found in that instance was that the original clinical champion really put so many things in place that it was easy for the replacement to kind of just keep things going. And then, you know, we meet with them routinely to make sure that they're getting all the latest and greatest information. And in the second instance, the clinical champion was maybe not quite as engaged as we would have liked. And we were able to leverage, Chelsea mentioned we had 2 practices that were in our baseline data, but we brought on a whole nother group of practices. And that clinical champion happened to be a pharmacist and really supported the change in the clinical champion from the other practice. So that worked out fairly well. And I'm very excited to see, you know, we've had a mix of clinical champions, some providers, we have a pharmacist now, and we've had care managers. So I think it's nice to have that diversity amongst the team. Change it. All right, so lessons learned. I went back to the group and said, hey, you know, can you answer some of these questions for us about for these uncontrolled patients, you know, because I don't see patients every day. What is it that made a difference? You know, how are you targeting these individuals? So the biggest thing that I heard, which showed up on Heidi's slides as well, is SDOH needs, you know, really listening to patients, health literacy, what's their ability to access the recommended treatment, medications, etc., and their ability to, you know, what's their neighborhood like? Is it safe? So that they can, you know, exercise, healthy food, those types of things. And so I wanted to share one success story. And this was a 62-year-old woman, and she has a significant past medical history with multiple comorbidities. At the time of her referral, her A1C was 9.2. She'd had diabetes for 20 years. She was on basal bolus insulin plus a max dose of Ozempic and was using a CGM. So pretty much, you know, maybe not the low carb pillar, but the other pillars of MCT2D. And then after listening to her concerns, it really came down to the patient had a fear of hypoglycemia and would wait until her blood sugar was high to prevent so she wouldn't be taking her mealtime insulin appropriately. So the interventions were around helping her feel more comfortable with preventing and treating hypoglycemia should it occur, as well as understanding the importance of timing her mealtime insulin. So all of this resulted in better blood sugar control, not a big surprise there. They optimized her medication regime, switching her from Ozempic to Mounjaro and adding an SGLT2. She made some lifestyle changes, added some diet and exercise, and after 5 months, her A1C was at the lowest in 10 years. So 6.2, she'd lost 10% of her body weight, reduced her basal insulin by 65% and eliminated her bolus insulin and was feeling great. So, I mean, that's really a tribute to this program and very helpful and appreciate all the efforts.
Hi, everyone. I'm Peggy Best. I am a lead care manager at OPNS, Oakland Physician Network Services. I feel like I'm kind of going in and out here. And I'm also the PO lead for the MCT2D initiative. So I think what I'm going to be talking about and giving you information on is our overall general goal and what that really is. Okay, are not only what our thresholds are for MCT2D, but also in our population, in our offices, all of our patients, decreasing A1Cs. So that is, again, what we're looking at overall. decreasing an A1C of 8% or less for all of our patients. What did we do? And I think we really focused on, I think I'll say three things. We focused on care management in our offices and our own care manager. And we think that that's essential in providing the health coaching, diabetes self-management, education to patients. Okay, our goal is to not only help patients get to a lower A1C, but to be able to self-manage. So generally speaking, what we would do in our offices is we would identify those patients who are uncontrolled. Okay, and that involved the entire care team. That involved the RN care manager huddling with a physician, huddling with an MA, or even the receptionist and office manager. Identifying those patients and beginning focused efforts on how are we going to help this patient lower their A1C and maintain that A1C. Two things we really focused on also is the use of GLP-1 medication, okay, and the use of CGMs. And for anybody who knows me, I love CGMs. I am like a CGM nerd. I think everybody who has diabetes or pre-diabetes should have this. So we would identify those patients, what are interventions, whether it be both of those or one of those. And again, targeted RN care management education. Number one, reaching out to those patients, making specific appointments for those patients. What we like to do is to get those patients in the office for face-to-face education. Okay, talking about perhaps the new medication. And I think that's very important. The care managers did a really good job with explaining to the patients what this medication is for, mechanisms of action, potential side effects, and then administration. We just didn't think it was enough to hand a patient this medication, right? All the education needed to be part of it. And then again, working with those patients and the CGMs. Again, we didn't think it was enough just to give the patient the CGM or do the insertion. And we felt that in order for a patient to realize all the benefits, they needed more education in terms of how do you use your data, right? What kind of treatment decisions are you going to make based on your data? How to retrieve your reports, how to do troubleshooting, all of those things together. We also targeted patients who may not be eligible for CGMs, and we know that that coverage is a little bit difficult. So we felt it was important to sample patients. We worked a lot with the two vendors, the Dexcom and the Abbott, in giving patients samples, maybe for a 2-week period or in a month period, because again, the information they can glean to make lifestyle decisions and changes is huge with the CGM. Patients are scheduled. We worked really hard at following up and scheduling those patients who have diabetes or even pre-diabetes with a 3-month planned diabetes follow-up visit. Okay, and again, the entire care team was involved. If at all possible, scheduling those visits on days that the RN care manager was in the office. Okay, so you can kind of take a look at the data here, and this is for one of our offices. So 314 patients have an A1C of 8 or less. 11% had an A1C of over 8%. So that's pretty good. And this is an all-payer mix. This is the entire patient population. Our goal, again, is to continuing to improve that number till we get to 100%. Challenges are patient engagement with care management. Okay, not everybody wants to talk to a care manager. We understand that. And then patient compliance with follow-up. And so we do have a certain population of patients, that really, and I'm sure all of you do too, that just kind of go missing, right? They'll have one visit and then we can't reach them, and maybe it's 6 months or a year later. So those are some of the challenges. And like some of the other presenters have been talking about, is those social determinants. Those are also challenges. Okay, thank you.
Right. Good morning, everybody. My name is Ashley Samara, and I am with United Physicians. A lot of what you hear is also kind of echoed what Peggy just presented on, so we've got a similar kind of intervention strategy there. Okay. The aim of our intervention was to increase the rate of patients with A1C values, because we did have quite a few missing A1C values across our patient population. We also wanted to decrease A1C values over 9, and of course over 8 as well, by ensuring their physicians had scheduled follow-up, had considered a CGM, or assisted a patient with obtaining a CGM, and then also connecting patients with care management support. We wanted to connect more patients with diabetes to care management support as well, with the goal being that patients were able to more closely monitor their A1C, their diabetes care, make changes, and of course, be self-manage their A1C. So for our interventions, we pulled a list of patients from the MCT2D dashboard. We use that all the time, so thank you. And use the PO data to identify patients that were currently enrolled or eligible for care management support, so focusing on our PDCM population. Patients were flagged on lists sent to physicians to help better identify those patients, and our care management team worked with those physicians and the physician champions to identify patients that would be a good fit for care management support and follow-up. The care managers encouraged and assisted the patients to get A1C testing if needed, provided education, or assisted patients with obtaining and understanding how to use a CGM. They also provided additional support to patients with suboptimal and optimal A1C values to hopefully continue them on that path. We also assisted physicians with getting comfortable regarding prescribing and interpreting CGM results, and connected them with training to help them make better decisions and appropriate changes. And we also launched group patient sessions with our diabetes educator, focusing on common issues that people with diabetes experience or might find frustrating or confusing. This allowed patients to share their experiences and learn from others on ways to overcome barriers. So for our outcomes, we have a rather large patient population and many, many independent physicians. So our care managers met with our physicians either monthly or bi-monthly to review patients. Of our patients, we just did a little snapshot. 522 were actually connected to care management support. 59 patients received a CGM to monitor their blood sugar values, and 458 of the patients, 458 of the 522 had A1C values. So we had 199 new values, so the patients did not have a previous value before. 92 patients had a reduction in A1C compared to the baseline data, which is awesome. So we always want to see that continued improvement. The physicians were appreciative of this approach as it allowed them to distribute workload and provide patient support outside of office visits and in between appointments. So for our next steps, we did find this strategy to be very effective and do plan on continuing forward with this approach. We do hope to expand participation in our group education because right now we haven't had the best turnout, but we're still working on increasing that and to continue to increase the number of patients with care management support. We did find that increased follow-up from both the PCP and care management has been effective in improving patient outcomes, so we hope to carry this forward. And that is it for me. Thank you.
All right, I guess I'm a little taller than her. My name is Malia Boss. I am the Quality and Community-Based Programs Manager for Holland Hospital Medical Groups, and I am a part of Holland PHO. I was invited to speak today on some of the strategies that we have been implementing to maintain a well-controlled A1C for our patient population for a number of years. While the data that you're seeing here today is specific to this collaborative, I want to acknowledge that our practices have really been doing this well since participation in CPC Plus, that was really where the driver for focus on our diabetic patient population came from for our practices, and where many of these initiatives and strategies started. The other thing that I think is important to acknowledge when we're talking about how does a practice do this well is really focusing more broadly than a particular patient population when it comes to a specific payer. So when we look at all of our patients, we're always looking at it from a population level, and we have been successful at reaching our A1C goals across all of the programs that we've been participating in for a number of years. So what are some of the strategies that we think might be helpful to implement that are working really well for us? One of the things that we have at our practice is embedded diabetes educators. These are functioning similar to a care manager. They cost about the same as an RN for the practices, and they are co-located at the practices. So the providers can grab them when a patient may need that warm handoff. And they really have been empowered by our providers to not only do some of that self-management education that a typical care manager would do, but they're also doing a lot of adjustments for making sure that the patients are optimized when it comes to their medications. We find that, I think, for primary care in particular, there are so many boxes that you have to check and guidelines that providers have to stay up to date on. And our diabetes educators have been on the forefront of adopting some of those newer changes. Our PHO used to yell at us and say that we were using way too many GLP-1s before the guidelines really suggested that. But it's because these diabetes educators really were acknowledging that this was working well for patients. And then our providers were working with these diabetes educators and trusting them, and also adopting that for other patients, knowing that had worked really well. A couple of other things that I thought might be important to share about the diabetes educators. We haven't been overly strict with our providers on who gets managed by a diabetes educator. The only real criteria that we've had is that they have to have diabetes. We don't have the capacity with our embedded diabetes educators to take on patients with pre-diabetes, but we don't say that, oh, the patient has to have an A1C above 8, because what we know is maybe the patient's A1C today was 7, but the spouse may have passed away recently, and this is a change for them, and they're only eating TV dinners. And so we haven't been overly strict with our providers about who gets referred. But what we found in 2023, that the average interaction with a diabetes educator, if they were interacting with them, was about 3.5 visits. So I think that's probably the sweet spot without having, the patients could have more visits or less, but on average, about 3.5% of our patients, 3.5 visits a year is what our patients were interacting with. When it comes for coverage, how many diabetes educators, we find the sweet spot for that is probably somewhere between 20% and 35% of the diabetic population. It depends a little bit on our practices. For internal medicine, where you have more patients with diabetes and patients who tend to also have comorbidities, closer to that 35% coverage really helps us manage the overall diabetic population better. For our younger family medicine practices, about 20% seems to be that sweet spot. We have a practice that is a family medicine practice that's been around and really established for a long time. The patients have aged with our providers, and that practice, even though the providers are still practicing as family medicine, we find that they really need closer to 35% coverage, just because of the way that they're practicing medicine in a family medicine style. So that's kind of the micro strategy that we have at the practices for how are we managing our patients with diabetes. On a macro level, we have wonderful support and direction from our PHO. And I think it's probably worth acknowledging, since most of you are POs, and maybe some of the strategies that you have could consider adopting. One of the things that they have done is they have created evidence-based guidelines for some of the specific conditions. They've taken some of these big 40-page guidelines that providers should know and put it on one sheet, and then really applied, okay, if the recommendation at this point is a referral, who are we all referring to? And so they have created some partnerships on our behalf, for example, for diabetics with the National Kidney Foundation, for being able to refer our patients to DPP. And that really has taken some of the burden off the practices to try to figure out who should we partner with? What is the recommendation for what we do here? They've also then taken some of that burden of some of just the administrative pieces of it. They created a BAA with National Kidney Foundation so that the practices specifically wouldn't have to do it. So that's some of the things that they've done to help guide the care that the providers are giving. Additionally, they have a variety of meetings with various audiences to ensure that this is getting done all the time. One of the ones that is my favorite, being the quality manager, is we have routine meetings with the quality leads at the practices to discuss challenges. You know, you guys all come to these meetings and you learn incredible best practices and you can come and share them. But I think what's really valuable with these is they come to the table and they really allow us to be able to give our perspective on why that might not work, or what's working well, or where should we push back, or what other barriers might we be experiencing. So they're very collaborative in how we can kind of discuss with one another. But then the other things that we have done is we've also created a micro and a macro level strategy for how we approach our patients. On a micro level, we really have to ensure that our care team knows what are we doing for these patients. So every year I ensure that each of the providers and each of the clinical staff at all of our practices understand what are the various measures that we're looking at. We apply them at a population level. Again, as I kind of mentioned, we have things available with them for them at the point of care to ensure that they can check those boxes easily, but that they also easily know, okay, for that particular measure, what am I ordering? How does this look? And I think that's very important to make sure it's easy for the clinical staff. The other thing that we have at a micro level for our diabetes educators is a report to look forward a week and who are the patients that are coming in, and they can use this report to identify, has that patient ever talked to a diabetes educator before? What was their A1C? They can do a quick dive into the chart if they need to, and then they can meet with the provider to say, what do you think about this patient? Should I maybe set some time aside so that I could be introduced to them by you at their appointment? So those are some of the micro level strategies. Oh, and then one more. We also are very intentional about talking with our patients about what we expect of them. We lean really heavily into our patient provider partnerships. And so before the patients leave, they really know and are communicated what's next steps for you, when do I expect to see you back, and in the meantime, what are other things that I need you to do, like get an eye exam or go to the lab and complete a chem panel. And then at a macro level, one of the strategies that we have that I think works really well is I have a dedicated quality team who looks at the patients who have not been seen and who have fallen through the cracks. So we're routinely outreaching those patients, getting them back, looped back in with a practice, get scheduled for a visit. And then the other thing that they'll do is they'll also look to identify which patients may have been seen, but may have not gotten looped in with diabetes educators that could have been and could have benefited. So thank you for inviting me today, but I hope maybe you guys learned a little bit about some of the strategies that you could apply at a micro and a macro level to cover your entire patient population.
Good morning, everybody. My name is Alex Tracy. I'm with Livingston Physician Organization. We're partnered with GMP Network for the PGIP program. And I want to say, Jackie, thank you for the invitation to talk today. We've gotten a lot out of the program over the years, and it's nice to be able to give something back. So in healthcare, we spend a lot of time talking about the patient journey, but we don't spend a lot of time talking about the physician journey. How did we get here? 15 years ago, when this started, the conversation was, why do I need an A1C? I take my blood sugar several times a day, and well, your insurance requires it. You only have to do it once a year. Well, once a year means that 15-year long journey was a series of 1-year sprints. Nobody was taking a longer term approach to managing diabetes. You get your patient list in May, you go as fast as you can just to get all your numbers in by December 31st. And as Tom Lighton likes to say, to go fast, go alone, to go far, go together. And he's laughing because he thinks that we don't listen to him, but we do. You say it enough, you know, we get it. And to get where we want to go, we need to go as a team. And to get our patients and our providers to work together as a team, we use PDCM care management. And really, this is about recognizing that physicians are limited in their time. You know, you're trying to squeeze that extra patient in because they're calling in for a sinus infection. And so the amount of time they have with a patient is short. So we use dedicated time with our care management staff in order to reach out to the patient, to assist them to communicate with the provider. And the way we do that is our care managers meet with the providers weekly. They go over patient lists that they get out of our registry Health Focus and use that to identify opportunities to understand the patient, to reach out to them, to see what it's going to take for them. Are they having trouble just getting time off of work to go to the lab? Are they having trouble with dietary restrictions? There's so many different ways that a patient ends up with a high A1C. So we have to figure out what it is for that specific patient that works for them, and that takes time. And from our experience, once the provider sees the results from the program, they get buy-in from their patients just by recommending it. That recommendation from the provider goes a long way in having a successful team-based approach to diabetes care. So we've really just been working on this approach for the last 2 years. We now have dedicated staff within LPO to work with patients in our care management program. And that really just allows us better opportunities to reach out to patients. And I think really the important takeaway out of this is not that we're doing anything special. We're doing the same things that you're doing every day, every year. There's no secret sauce. There's no magic bullet. It's all just putting in the work. Every patient gets at least 2 touches per year from the care manager. They make sure that they're getting their medication on time. They make sure that they're getting their lab work done. They make sure that they're following their diet, that they're seeing their physician on the regular schedule, and they make sure that the physician is getting updates along the way. And with that, we've really seen a change in how we approach diabetes, how patients are approaching their healthcare in general, and allowing them to really understand the longer journey that we're on. And, it's nice to have descriptions on slides and to read it all to you, but it really ends up just being about that team-based approach and having the trust between the physician, the patient, and the care manager. So, thank you.
All right, let's give another round of applause for all of our presenters. Thank you so much for sharing all your fabulous work. So we have maybe 5 minutes for questions. Does anybody have any questions for our presenters? I can walk.
Thank you. I love the presentations that you guys gave, and especially noticing that you have to kind of seize that opportunity when these patients are coming through the office to then connect them with those various care team members, especially our care management or diabetes educators. Do you have any specific experience or things that have worked well with involving office team members other than the provider or MA? I'm thinking like check-in, check-out. What we're trying to really explore is how do we get as many team members or as many layers in place, noting that it's really hard for the providers to always remember to make those referrals is what I'm just to be clear.
Yeah, I can take that question. I don't know if this is on or not. Okay, it is. So one of the things that we focus on for our offices is making sure that you do the pre-visit check for the patient. So you're looking to see what their preventive health recommendations are. You're looking to see their medication refills. There's always somebody reviewing that patient's chart ahead of the visit and communicating that information to the provider. And that can be a medical assistant. It can be a dedicated person depending on the size of the office. But it's invaluable for the providers to have that information just in one sheet right in front of them. As soon as they see that patient, they know everything they have to do for that visit.
The other thing that I thought of is through the various CQIs, as some of the guideline changes occur, or there's best practices that we think would be really helpful for our practices. You know, we just really kind of go back to the basics. You know, PCMH is a prerequisite to be able to be in this program. And so it really just goes back down to your planned visit. And are you revisiting that? Are you updating that? Are you including the new guidelines in that? And then how are you training your staff from everybody who, you know, touches the patient or even doesn't, you know, even if it's just a reminder to get labs done ahead of time, but really looking at who all needs to be involved in the patient visit, from pre-visit, during the visit, post-visit, and then what are the specific roles and responsibilities, and then how are you communicating that with each person?
Thank you. All right, we gotta get moving, but I just do want to remind you, you have part of lunch is networking. So if you have more questions for our speakers, please utilize that time at lunch to interact and ask questions. So with that, I'm going to turn it over. Sorry. Has to happen one meeting. I'm going to turn it over to Lauren and Jake.
So we'll let folks, thank you, you're released from the pressure. Everyone's doing a pretty good job with this microphone, which I feel like has like one good spot. So let me know if this is appropriately loud or soft. I'm gonna start this discussion. I'm gonna turn it over to Jake Reese to handle a few of the more technical aspects and then talk a little bit about some data that we have from some of our practices about this new performance measure. We're very excited to be expanding to have 2 performance measures now. And as Heidi and I have reiterated, we selected something for our first performance measure that was highly aligned with what you're already doing, that we felt you were going to knock it out of the park on. There was no chance of failure, and is really so important. I think for me, even seeing that we had a 2% improvement in A1C control, maybe over our commercial practice, that's, you know, of the 100,000 patients that we have in our dashboard, that's a lot of actual people who are enjoying the benefits of better blood sugar control. Even incremental improvement in a huge population like ours really makes a difference to patients. So I'm really just so pleased at that. And I think now we've transitioned into picking items that maybe we're not performing so well in. There's a bigger opportunity for improvement and improving patient well-being and outcomes. and then potentially some more opportunity to get it right and to have some pitfalls in how we roll this out. So we have tried to get as much feedback as we can, but today is another opportunity for you to help us identify and troubleshoot what are we not thinking of? Is there anything that you see being a concern with this new performance measure? So thinking about the next performance measures that we will look at and the measurement goals, things that require effort and aiming to reach for a stretch goal, but something that still will be achievable. And so this aligns with the HEDIS measure for kidney health evaluation. You're already working on this, and that HEDIS measure looks at age-based population from 18 to 85. If you make it to 85, we're no longer worried about your albumin. Not no longer worried, but no longer putting you on a performance measure. And it's, again, as Heidi mentioned, both type 1 and type 2. So what we're changing is reducing it just to that type 2 population. And then for HEDIS, we're looking at the GFR as well as urine albumin creatinine ratio. And then you can see those current HEDIS measurements, wide variety off of practices and POs, but you're at the 95th percentile if you are getting 65% of your patients measured in a year for commercial and 62 for Medicare. Pretty similar, honestly, across those two populations. And so I'm going to have Jake come up and ask him to go through the fine print. He's explained this to me several times. I'm still working on getting it, but I'm going to ask you to go through these slides and then I'll talk about the feedback.
Thank you, Dr. Ashman. As per usual, I have the distinct pleasure of talking about highly complicated and technical items at you at a very high rate of speed. So without further ado, here we go. So the uACR measure is going to be our first measure that's going to kind of span a little bit longer time frame. So the first thing to note here is that it's going to focus solely on urine albumin creatinine ratio testing. The KED measure, as most of you will be familiar with, also involves eGFR testing. Because of a lack of data completeness in our data systems, we are focusing solely on uACR, the spirit of the measure being that you should be getting both tests. However, for the purposes of the MCT2D performance, we are just looking at uACR. So that really means that this is a process measure, not a performance measure at its core, because we are looking at whether or not the test occurred, not, I'm going to adjust real quick, not the actual result of the uACR. And so this is looking at during a specific time frame, did a patient have a uACR done? As we know, the clinical guidelines for patients with type 2 diabetes is once a year for uACR testing. So as with our performance measure currently for A1C, this is going to be the Blues population, the BSM, BCN, commercial, and Medicare patients. We will be using the attribution files to identify the patients that will be included in that. And then after those patients have been identified as one of the Blues patients, we will be using also the ACRS attribution model, which is what you as the POs are sending to the Michigan Health Information Network to help us bring in additional Blues patients. But again, they have to be Blues. That's the technical jargon that you will not remember and you don't need to. It is a 14-month time frame, so it is a little bit longer than that A1C measure. And the purpose behind this being, we know that even though it's a 12-month clinical guideline for uACR testing, a patient may not be seen for 12 months and 1 day simply due to like pedantic life circumstances. They don't get in to see their primary care, or their primary care doesn't have an available appointment before that 12-month period ends. And so we've extended this out to a 14-month period to make sure that we're giving that grace period for patients to actually get that test done. It is, as with the revised year 2 A1C measure, a practice level measure. So it's not going to have aggregate groups, just like we are shifting away from this year for A1C. And we are aligning both the primary care and the nephrology sides of this performance measure together. So nephrology practices and the collaborative will also be working on this in the same time frame. All right, so the target rate. So we are looking at a 10% absolute improvement up to 90%. So it's based off of where your practice is at a given point in time, and then trying to increase that by 10% for the performance year. Because this is a process measure, the important thing here is that obviously you're looking at a time frame and you have to repeat performance. So at any given 12 or 14 month period, let's say you have a 75% performance for that 12 months. If you're going to have a 10% improvement on that for that measurement period, that 14 months that we'll be looking at, you would need to go to 85% performance. And so this isn't going to be quite the same as A1C, where if you're meeting it, you get to just kind of coast. You have to repeat your performance, which ideally should be relatively simple because you already have the workflows in place to do that. For practices that are starting above 80, you only need to increase your performance up to that 90% threshold. You don't need to go that full 10%. For practices that are above 90, again, we just ask that you repeat that performance from the baseline period that we're going to be providing you that performance for in the performance period. So it's just a matter of repeating the performance you're already doing. The number of patients that are needed at each practice to reach that improvement will range. Right now, from some preliminary analyses, we're seeing somewhere between 2 and 296, depending on practice size. And so it's going to be very individualized. All right. So the baseline period for this that we're going to be looking at is January 1st, 2024 through February 28th of 2025. So that baseline report will be distributed very shortly. This is a typo. It's not May 2025. It's going to be a little bit after that. But we will be getting a baseline performance report out to you. The measurement period here is from July 1st, 2025 through August 30th of 2026. And so as you can see, that's that 14-month period to account for any patients that may not be seen exactly 12 months since their last visit. Bless you. All right, so the measure weighting for the purposes of VBR. So for 2025 or 2025 to 2026, so the 2026 VBR payment, this is not going to be accounted for on that VBR scorecard. This will start showing up on your 2027 scorecard because of the timeline that we just looked at here. Oops, wrong way. So as you can see, because that performance period goes all the way through August 30th of 2026, you wouldn't be done in time for that 2026 VBR scorecard. So this will show up for the first time on the 2027 scorecard, and we'll show you what that looks like in just a second. So on that scorecard, the way that the weighting for this is going to work is starting with actually the 2025 one, Blue Cross is no longer separating out performance from participation measures. It will be a score-based card, and you'll be able to gather points both from participation measures and performance measures that add up to a specific point threshold, just like a scorecard you would get in school. And then whatever your point score is will correspond to the level of VBR you receive. So if you have between 55 to 69.9 points, you'll get 102%. If you're between 70 and 84.99, you'll have 103%. And if you're 85 or higher, you'll get the full 105% VBR. And so, like I mentioned, this is what it's going to look like on that this is the kind of the timelines for the VBR scorecard. So as I mentioned, the 2025 to 2026 scorecard is going to just have the A1C performance measure plus all of your participation measures that you're very familiar with. And then starting with that 2027 to 2028 scorecard will have both the uACR and the A1C measures, which will have those two different date ranges for performance, but we'll look at what that scoring is going to look like now. So for the uACR, as I mentioned, it's based on that 10% absolute improvement in performance. And so if you have that 10% plus improvement up to 90% and or have improved up to 90%, if you're at 82, you don't necessarily have to have that 10% like I mentioned, or if you were already at 90 and you repeat that performance of 90, you'll get that full 100% credit for the measure. If you have an improvement between 7.5 to 9.99%, you'll get 75% credit. 5 to 7.49, 50%, so on and so forth, down to 0%. So this is a little bit different in that it's not a yes or no, meet or don't meet type situation. If you have a specific type of improvement, you'll get a partial credit for that improvement level. All right, so on the dashboard, we are going to have, we actually currently have a way for you as both the PO and your practices to view patients that have had, as well as what their uACR tests were actually. It's already built in. So if you go to the renal details tab on the patient dashboard, it is the other patient list version. So you default to that patient list tab. If you go one to the right, there's one called renal details. You may click over there on accident and think it looks exactly the same. It's a little different. That's going to be where you could put in filters for renal specific lab measures, including the uACR testing. It'll have both filters for identifying patients based on specific numerical values, but more importantly for this measure, you'll have the ability to filter for patients that have no uACR on record with any specific time frame. So that functionality does currently exist in the dashboards. All right, I'm going to pause for a second. Are there any questions right now on this before I turn it back over to Dr. Oshman? Yeah. So there's only uACR for MCT2D. That's so for the purposes of the performance measure, we are not looking at eGFR, only uACR testing. So yeah, so we are looking specifically at urinary albumin creatinine, which is the ratio. So the ratio of the two, that's what we're looking for, which is a independent standalone value. Yes, and we also are looking at claims though, because this is a process measure. We're not only dependent on the clinical data. We can use claims to discern if something actually happened, even if we don't have the clinical value for it. Yes. Yeah. I'll credit Jackie on that one. So this has been a struggle. Labs build very differently for urine testing. We know that certain labs, you may only order a urine albumin, you may only order a urine creatinine, and you get both. We are specifically looking for the result for the urine albumin creatinine ratio. But we have had some success, at least with Michigan Medicine, in trying to standardize. But as you know, there is no current CPT code specifically for urine albumin creatinine. So however it is that you're billing, keep doing it and we'll capture it. Yeah. Mm-hmm. Mm-hmm. Yep. 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 Yeah. And hopefully one of the things that could simplify this again is just because this is only the blues patients. Hopefully the insurance type is a little bit simplified there. Not sure if that's going to solve it at all. No, it's different for VCN. Yeah. Okay. Yeah.
Looking at their relationship with labs across the state, I believe we have set this up for you to be successful, but I would like to talk
Yes.
to you at break and get the names of those labs.
Yeah.
And I think that goes for everyone, that if there are labs you're worried about, to have this conversation.
Yeah.
Yeah, so, and for us, my area, for the eliminated all of those labs.
Okay. Yeah.
Work on that with you.
Yeah. Awesome. All right.
I'll take over. They did talk about the tiered improvement, but I think it's clear that if someone's already at 82%, they still get the 10% improvement if they go to 90.
That's the point.
Okay,
Yeah. So if you're over 80, you only get to 90, and if you get to 90, then you get that top 100%.
Yeah.
Yep.
Great. Thank you so much. These are great questions. I feel like we're trying not to fly the plane as we build it. We're trying to build it first, but these are exactly the kinds of things that we want to address with you early on. We really appreciate it. I have in my mind worry about our patients with Medicaid and worry about potential changes in federal policy on our patients. I think from the perspective of these performance measures and helping your practices do well, we are still limiting our work to people with Blue Cross insurance. Does that address my bigger concerns about diabetes in Michigan? No. I'll save those for another time. But if you have other questions specifically about the performance measure, do let us know over lunch. What I want to share with you in the last few minutes before we go to lunch, we asked practices before the end of the VBR year, when they're really hungry to do something easy to earn credit, we give them surveys. So we gave them a survey asking us to tell them about what they're doing with their uACR screening and launched this last month. And we have 114 responses that are shown here. Of those responses, they represent 22 of the 24 POs. So at least one practice responding for most of you. So the good news is that 80% of the practices who responded have a system to track which patients are overdue or due for uACR screening. And the different kinds of screening mechanisms that they use might be a quality dashboard using the built-in dashboards from Epic, or a combination of those and manual reports. In terms of effectiveness, I think for practices who have this, it's going pretty well. They consider these systems to be fairly or very effective. I think it may be important to identify which practices feel like those tools are not working and why. And it may be because of some of those issues. Even if we have the tools, then the patient can't get to the lab to get the testing done. We asked who manages screening and who manages those prompts. In my office, I tried to fill out the survey and then I realized I didn't know the answer, but Caitlin might. I think it's the medical assistant, or do I have to do it? We can talk about this at lunch. That's what I thought. So it's this idea that either the primary care physician or provider is responsible then for managing that screening. There's some shared responsibility, or it's the medical assistant. And then when we think about the availability of those prompts, again, like a practice alert, do I have to do this now? Is it due? My least favorite thing is I see the patient and then the thing is due the next day. So I didn't get the prompt and then it's another year before they come back. And so of those who responded, they feel like it's pretty helpful and used consistently, but not everyone is using those prompts that already exist. We asked them, what are the practice or workflow barriers to getting this testing done? And this, again, is creating ideas for all of you. What do we want to change? What do we want to help them to change? And as I expected, there's write-in answers that are the majority of their comments, but that is coordinating staff. I think that's Caitlin and my issue, is getting this pended for patients while they're in the office so that they pee before they see me and then don't leave before peeing on the way out. And then resources and time, team constraints. There's lots of different things we're asking our teams to doing, and technology and reminder systems. The order reminder, I think, is a big opportunity for improvement when we can initiate that in our electronic health systems or other manual systems. Labs not completing the correct test, we have some resources that we're thinking about to help with that. Urine testing in office, I think, is a real frustration because then you lack control, right, of when the patient is going to an external office. And then, is this test due or not? And I think we're trying to address that. We think there's a lot of misunderstanding. uACR should be done every year, even if it's good, even if it's bad, to see where it's going. And so that is part of the messaging that we're pushing out to the physicians and practitioners across this year. And then whether we're ordering the right test or not. And then patient level barriers. I think, again, I don't know that we can solve this problem. I don't know that I can order in systems for us to be able to do this test, or at least order it and then send it to the lab from the office, but that is clearly identified as a barrier. Some of these barriers, I think, are out of our control versus in our control. External labs, other reasons for follow-up, and then transportation issues, and then a piece of understanding why it's important. So maybe there are some things we can do together to try to message to patients. Maybe they would go to do this if they understood that it was really important for their kidney health. And so then we asked what we can do and what the practice might do. And some of the responses were about educating both patients and practitioners, workflow optimization, doing more chart audits or reminders, scrubbing the chart before the visit, patient engagement. If you do have a lab on site, maybe getting the patient to leave the sample, in-house versus out-of-house testing, bridging gaps in care, and making sure that we're conducting regular check-ins for those patients maybe who are only being seen once a year, team collaboration. And I think this is really where, as the doctor, I don't want to make this decision. I would love for a medical assistant just to obtain this lab for me once a year. Technology and alerts, like we talked about, and then frequent follow-up. And then we asked finally, and then I'll send you on your lunch break, how can we at MCT2D, what's outside of your locus of control that we can help with? And that might be creating those educational resources, doing a better job updating our dashboard with information about which patients are due. We are constantly working on the lag time. I will be happy when we have next day results. But my team at MDC in the back of the room is sweating. Next day results. immediate updates, but we're trying to reduce that lag time. And when tests have been done, sharing workflows and best practices, we're going to do a little bit of that after lunch. And then how can we help with patient engagement? Is there something we can do as a collaborative? Technical support, so there may be things we can do. As we've told you, we're launching an EHR work group, and so maybe there are ways that we can save some time and effort for you looking at different EHRs that people are using. So with that, it's exactly 12.
My name is Julie Wright Nunes. I'm a kidney doctor. I work at the University of Michigan. I see adult patients with advanced kidney disease. And like I said, I'm super excited to be part of the collaborative. I'll be moderating the session, but to start out, we're going to talk a little bit about some introductory slides, just as a refresher, things that you've seen before, but just to make sure we're all on the same page. So when we talk about preventing chronic kidney disease, we think about kidney disease kind of as those green squares in the middle, going from risk to progression, kidney damage, and then hopefully we're preventing kidney failure and death. The bottom are all the things that the patients do to keep themselves healthy. And at the top, you see kind of a continuum of care from primary care and nephrology. And what we know through research is that most patients who have kidney disease, even if it's very advanced, are cared for solely in primary care. So thank you for what you do to care for our patients. And when we've been talking about care and some of the measures that we're focusing on as part of this collaborative, of course, the main measure is urine albumin to creatinine ratio. Quick refresher, what is albumin? It's a protein in the blood. It's not supposed to be in the urine. If it is, that means there's been damage to the kidney. And so that's one of the areas that we check for to see if there's kidney damage. And the reason that we care about urine albumin is because, one, it's part of the diagnostic criteria for kidney disease. So even a little bit tells us there's damage and kidney disease in the urine, or excuse me, kidney disease when we see it in the urine. It's also associated with other bad things. So all of these things listed here, kidney disease progression, acute kidney injury, bad stuff with the heart, and mortality are associated with albumin in the urine. So that's why we care about it. And it's a therapeutic target because if we can reduce it in the urine, then we have less of these bad things happening. And again, that's been shown through research. This is a heat map. And if you want to refer to it, this is a link that you can look at for the guidelines that we use for treatment. But what we're showing is kind of across the top, albumin from being normal to more severe, having more of it in the urine. And then here we have these G's standing for GFR, so the filtration being normal to high, down to kidney failure. And the take home is that as you progress down and to the right, people are getting into more severe categories with higher risk for the bad things that include progression and all of the other things that we listed. When we talk about urine protein testing, that's different than urine albumin testing. So urine protein is basically, I know urine for a real treat. I love that. But so there's different types of proteins. Albumin is just one type. And the reason that matters is because sometimes as clinicians and also as kidney doctors, we might look for all of the proteins that can be in the urine. But albumin's just one type of it. And the dipstick test that we use to do spot tests to see if there's albumin in the urine are chemically reacting with the albumin with a little dipstick reagent on the pad and telling us if there's that abnormal amount of albumin in the urine. And the reason I'm talking about this is because it doesn't test for other proteins, but it is a qualitative test. The quantitative tests are tests that we can do over 24 hours, or we do a spot test when the patient pees in a cup, and then they can actually find out the concentration of albumin in the urine. And the reason we ask for the creatinine too is because if people drink a lot of fluids one day and all you're getting is the level of albumin in the urine, it's not really accounting for how concentrated the urine is. So that's why we get the creatinine. And that's why the urine albumin to creatinine test is what we advocate for. It's also been shown to correspond to how much albumin a person loses in a day from their urine. So research has shown it really correlates with that too. just a couple common misconceptions, and then we'll invite our panelists up. Sometimes we'll hear the patient's already on medications to stop urine albumin from spilling out, the albumin from spilling out into the urine. So we don't need to keep checking urine albumin, but we do because we need to see how that therapy is going and consider if we need to add on other agents or increase the amount of the medications they're on. If the urine is negative for protein, we don't need to check the albumin, but we just learned that there's different types of proteins that we can pee out in the urine, and the albumin is a specific one, so it's not the same thing. Urine albumin is not just important for diabetic kidney disease, it really signals any kind of damage. You spill this out from any kind of damage done to the kidney, whether it's hypertension or other types of diseases. And then lastly, I kind of already touched on that it's not the same as protein. So sometimes we'll get questions about clinically, how often should we be checking urine albumin to creatinine ratio? And again, this handy little heat map, which has the link to it right here if you ever want to look, is included in our guidelines of when we can screen for albumin in the urine and at what levels of GFR. When we might treat with medications, and then how often we can continue checking, which are these numbers after. So that's just a quick little synopsis and hopefully some helpful tips. And now I want to move on to the exciting part, and I'm going to invite up the panelists, and we'll talk to them about things that they've done. So Rebecca, Katie, Molly, and Larissa, if you could come on up, and if you can just take a seat at one of these microphones. Super, thank you all. So we're going to do this in kind of a structured way, but we also want to have questions organically, so feel free to raise your hands. But the first thing I'll ask you all to do is just, and we'll do it in a row here, just if you can introduce yourself, where you're representing, where you're from, what your official title is, and then maybe what your real roles are. And we'll take like a minute to do that for each person, and then we'll start getting into the questions.
Rebecca Vermont from Answer Health Physicians Organization. Hello. Is that on? Try it again. Rebecca Vermont.
It looks like it's on, maybe a little.
It's
okay, great.
Make me shout. Okay, again, Rebecca Vermont from Answer Health Physicians Organization. I'm a clinical performance specialist and serving as the PO admin lead for the CQIs.
Welcome.
Hi, I'm Katie Nagy. I'm one of the practice transformation specialists with Great Lakes Physicians Organization. I work with the practices on quality and cost of care and also the patient-centered medical home program.
Super.
Hi, I'm Molly Mason. I'm a registered dietitian by trade. I'm with Oakland Southfield Physicians, and I'm the CQI project manager for Oakland Southfield. And I do still do some care management related to MCT2D.
Hi, I'm Larissa Rappin. I'm a registered nurse and a certified risk adjustment coder with St. Mary's PHO. I work on various projects with the PHO, and one is the MCT2D, as well as the CKD predictive modeling program. And I assist with identifying the correct lab orders that should be placed for patients with diabetes, as well as education for the providers.
Super, thank you. We're just adjusting the mics, and if that doesn't work, we can kind of try to hand it over. Thank you. No, I appreciate it. So we have their first question here, and it's how has your organization supported practices and improving rates of urine albumin to creatinine testing? And then what challenges do your practices face with doing this? And we'll actually start from the end of the table and have you start, and then we'll kind of move our way forward. And I believe one of you have a slide, so just let me know which one of you that is.
Over the last several months with this. Can you hear?
And if not, I can hand this over, but.
Yeah, I think.
Okay.
Yours is
Oh.
So good for them.
Oh, okay. There we go. I feel like I'm gonna be yelling now. Just over the last several months, we've been really focusing our energy on making sure that the correct lab is in our various EMRs that we have throughout our PO. We did go through a merger and are primarily using Epic, so we're making sure that the correct lab is available for our providers. And part of that is making sure that it is mapped correctly, and just also really focusing our energy on educating providers on ordering the correct tests. So we've provided screenshots for our providers so that they can easily identify that test in the EMR. A big part is also educating on the KED measure and the guidelines associated with that measure. We have utilized our quarterly meetings to pass along that education over the last several years, and that seems to be a good platform or a good opportunity for the education.
Super. So reminders, triggers, and then communication.
Yeah.
Awesome.
Yeah.
Great.
So at Oakland Southfield Physicians, to support our practices with the uACR testing, our first step was to educate our practices on the change to the HEDIS measure from the retired measure, which was the monitoring for nephropathy, to the current KED measure. We did notice that a lot of our practices were still ordering the 82044, which closed the retired measure but doesn't close the current KED measure. So we did conduct a claims analysis to identify practices that needed additional education on what to bill and how to bill properly. And then our PCMH practice representatives did reach out to those practices directly to inform them on correct billing. We do still monitor for the 82044, but we've seen a decrease in that billing. And then additionally, we do use what we call quality worksheets at OSP to inform about open quality gaps. The KED measure is included on these. Those are informed by health claims data that we get, and then that data is updated monthly, and practices can pull this from the OSP website in real time, and then our practice representatives do also take those reports out on a regular basis. Are we talking about challenges too right now?
So, yeah, sure. Please mention if you have, well, probably a few.
A couple. So we did find that the lack of understanding around this measure in terms of the complexity of it, the changes, the practice education, the lab education, that was really challenging for us. We did have a situation where an OSP practice was told by DMC to bill the wrong code. I mean, so we've had some, and then also, as we've already heard today, the JVHL labs being the only in-network lab for the BCN, BCNA population. What we were finding was that any labs done outside of those JVHL labs were considered out of network. The member would have to pay. And so the lab just chose not to bill those members. So the test was done, but it wasn't ever then reported to close the quality gap. So that was challenging because that's outside of the PCP control.
It is, in fact. And so really, if we map out the processes, I guess what we have to focus on is what we can control, and then try to follow up with how we can capture those things that we should be actually getting credit for. Thank you.
For Great Lakes Physicians Organization, we focused on education, reporting, and workflow. So first was education. We had to really educate ourselves, first of all, with this measure, because it's quite an intricate measure. And then we took it out one-on-one to the office managers. We also did group education with the office managers in our quality spotlight meetings. And then the quarterly office manager meetings was also presented at the quarterly PCP meetings as well. Reporting, we have a variety of reporting that we give to our practices. In February, we give out the gaps in care that weren't closed from the previous calendar year so that they have a head start instead of waiting till May when the official attribution list and gaps in care come out. And then we're reviewing those quality summary report cards with our providers monthly and taking out their patients that still have open gaps in care. And then it was workflow. One interesting piece to this was working through with our practices that have all different EHRs. From the time they were entering the codes into the EHR to be sent to the lab, we found that many times the CPT codes weren't being connected to the lab order. It was just a brief measure description. So we were leaving that final CPT code decision up to the lab, and they were choosing codes that didn't close the measure.
Okay.
So we were able to correct that in a number of practices. So
That sounds great. And I think what struck me and what all of you are saying is that we're also identifying opportunities for improvement outside of our area, which maybe is not what our intent is, but at the same time, it's great as a byproduct of what we're doing. So kudos.
I might sound like a broken record because it sounds like we all have very similar processes. But Answer Health supports the practices with the testing rates through several initiatives, but mostly through our PCP work groups, which we actually hold monthly. We've done the kidney health evaluation, has been featured several times throughout the last few years. And as a best practice topic. And then to ensure the accurate testing being ordered, we did very much the same as these other POs. We researched and shared the correct lab codes for each local laboratory because they're all different. We encourage practices to verify that the appropriate test codes were available in their EMR lab compendiums. Again, we had recently a lab in the North region had a big lab change and they dropped all their LOINC codes out of their system. So somehow the practice is ordering the test, patients are completing the tests, they're not getting counted because the lab just is not reporting them out correctly. So issues like that we're working through. And then distributing the measured tip sheets, both from the payers, and we also have some Answer Health branded tip sheets that we hand out to the practices as well. And then as far as challenges go, it sounds like we all kind of have the same challenges as well here. The lab related changes are a big one. So updates to the test codes, the LOINC codes, cause those miscommunications between the EMRs and the lab ordering systems. And then another significant challenge was the need to retrain the providers when the measure changed. So historically, with it being just the urine microalbumin alone, changing to the uACR, it just created some transition in the provider workflows and just working on ongoing, I think, education and training of the staff and the providers who are ordering those tests.
Great, super.
The challenges, yeah. So I think one just kind of ongoing and continuous process would be like we discussed the provider education because the measure does change, and I think that that's just common in medicine and in patient care. So just making sure that all the staff and the providers are up to date on that. And I think that by the time we get everybody up to date, it feels like the year is pretty close to being done and we're going to be doing it again. So just making sure that that happens early in the year and that we're continually having that open dialogue and, you know, clarifying questions that anybody has, that we're making ourselves available. And then patient compliance, I think, is a big one. So completing the recommended testing, completing it when it is due and hopefully before their upcoming appointment so that it can be reviewed with their provider. That can be challenging, and it is challenging, especially in our rural communities where a lab is certainly not in the office. And we try to recommend to patients that they have the full panel of testing instead of doing one lab here, one lab there. And that can be, you know, paramount to their health, and it can certainly help to ease their concerns as far as the lab costs. So, you know, like I said, just having that kind of ongoing dialogue with, you know, the whole care team, including the patient.
Super, thank you. Are there any questions to this point? Otherwise, we can move on and ask a few others that we have. And I think one of you has a slide to present too. Any? Okay, great. So how do you approach the billing? And we've touched on this a little bit, but we can also kind of circle back to it. And what codes are your practices ordering? And I believe there's somebody who wanted to use the slide, so just come on and up and I can help you with that.
It was me, but it's just that one slide if that's all it is.
So you can start.
Okay. Thank you. So I keep talking about these quality worksheets at OSP, so I thought it might be helpful if I showed you what a quality worksheet looks like. So this is what our practice is.
I think we're cracking the code that you have to put it in just the right spot. It's like
yeah, it's very
inches away.
Really close.
Yeah.
So this is an example of a quality worksheet from Oakland Southfield Physicians. This is something that we do produce. And so you can see that this is an example of what a KED is, because that way you can look at it. Okay, that sounds great. This is an example of what a some information that we would give on the KED measure. So you can see that it does show whether the EGFR component was met or not met. And then we show that you need an 82043 and an 82570 on the same date of service. And you'll see on that first box there, one of them is missing. So for example, missing 82570 and then on what date they missed that on. So that would indicate to that practice for that particular patient, so this is patient specific, that they need to reorder both of that test and build both of those codes on the same date of service to close the measure. So this is an example of how we're helping our practices understand what they need to bill.
Fabulous, thank you. And can you expand, like, how did you develop this worksheet? Was it just a multidisciplinary team?
So our team at OSP puts these together. So we use health plan data. So we get that monthly, and then you can pull this, each physician or office can pull it from our website in real time whenever they want to look at it. Or we have practice reps that take it out to the practice.
Super, thank you.
Thank you.
Okay, others who would like to contribute a little bit more information, if you have anything to add? Start with you.
I think the billing piece mostly comes from the lab, but as somebody mentioned before, if the way that your lab is being ordered through your EMR isn't quite connecting the correct CPT, you're leaving it up to the lab to choose the correct one. We have found issues then with the lab not picking the correct one. And then also I know that MCT2D is not going to be measuring EGFR, but the payer measure also includes that EGFR, which causes some confusion with lab ordering because of the 4-day window of that needing to be done. I'm sorry, let me back that up. These need to be done within the 4-day window, but with the addition of the EGFR, it creates confusion, and then the practices think that the 4-day window is between the EGFR, and they're just ordering things at all sorts of different times. And then sometimes the EGFR gets captured at a different time during the year because it's ordered for a different reason. So they think they're done. So then they miss the urine test. So I think that just kind of does pose some billing issues with what's being chosen in the EMR with what's getting billed out at the lab. And then the other challenge then that comes along with that is because it typically it's claims that are capturing these. I just lost my train of thought, but I don't know where I was going with that. Sorry.
No, that's okay. Just some other challenges related to it.
It's just, I think the billing in general is the challenge because of the difference between when they're capturing the CPT codes.
No, totally understand. I think that's all a mystery to me, and I've been doing this for a couple decades. So thank goodness for all the people who helped me with this. Did you want to contribute anything?
Just making sure that all 3 of those codes are captured to close it, and then providing reporting, like your example of who was missing what piece of it. I'm trying to get them all.
Super.
Yeah, I mean, I think, like we mentioned before, just making sure that the labs are mapped appropriately and really just emphasizing to all of you that it's not an automatic thing. You'd think it would be, but it's certainly not. And it does require kind of looking at it on the front end of whenever you're starting a measure and making sure that if a measure changes that you're going back and looking at the mapping and that it's still lining up with everything that you need to close a measure. And I think too, you know, for patients that I'll frequently see it come back and say that it, you know, like the ratio couldn't be measured.
And when you say ratio, you mean the albumin to creatinine?
Yeah.
So they're saying that they can only get the albumin without the creatinine, or?
Yeah, it'll come back and
I understand.
It'll just say it couldn't be measured. A lot of times it's because the result was so low that it just couldn't be measured. But just clarifying with patients that, you know, the first morning void, just that education to patients, I think is so very important. And we're all so busy that I think sometimes it can slip through the cracks, but developing these tools to be able to give to patients, you know, when we talk about giving them a printed lab order, something that can be handed with it to say, these are your instructions to go with it is important too.
Absolutely. And we're all on the side of care. So maybe this is kind of seems seamless to us, but I'll tell you, as being a patient, as I've gotten more vintage in my years and going to the doctor more, and, you know, things can be quite confusing. So, and I think also we're bringing up things for a parking lot or for discussion later related to when we actually do order and getting credit for that, sometimes it may not come through for a variety of reasons. And how do we handle that as far as the credit that we should be getting for actually doing our part in it? Okay, great. So, how has your practice, oh, I'm sorry, I'm actually interested in moving to the next question about quality improvement tools. And they don't have to be quality improvement tools per se, but things that you do, you're talking about, well, we sent the codes to the lab. I mean, that sounds like a big deal to me. I mean, I can't imagine just like mailing it and saying it. It's like quite a process. And I'd be really interested in hearing, and probably all of us as well, just in the last 2 to 5 minutes here, if you could tell us about the processes that you use to make these improvements. Was it with the multidisciplinary teams? Was it the meetings that you had talked about? Some of you mentioned doing reports that weren't just at the end of the year. So if you could kind of boil it down into the things that you really saw made you successful in what you did, maybe that's what we could leave everybody with. So we'll start in this end again.
I think a few things that I already mentioned, just the continued conversations with the practices, reminding them about the test. The tip sheets are super helpful. The tip sheet that I made that's Answer Health branded is very, very slim. So there's not a whole lot for the providers to look at and have to read through. So I think that's helpful, is just giving them a condensed version of the information that they need to know. And then also an additional step that we have made is reaching out to the laboratories ourselves and trying to figure out and troubleshoot the reason why codes aren't getting reported or what's getting missed. Because very frequently we would have results that come in, but the codes aren't reported. So we just need to figure out where that gap is coming from.
Fabulous. And I love tip sheets, so thank you.
That's what I was going to mention, was the STAR measures tip sheets. Everybody likes a good summary. So that's been helpful, making sure the correct codes are on the lab slips. But I think it sounds like we need some sort of statewide lab education, maybe on the wish
Yes,
list.
I love the way you dream. Our next collaborative.
So Oakland Southfield Physicians is an independent physician organization, so we don't have a one-size-fits-all solution for our practices. So we found feedback loops with practices to be the most successful. So reviewing performance, identifying issues, adjusting workflows at a case-by-case basis, practice by practice, to be the most successful.
Super.
Yeah, we've developed essentially a clinical advocate program where we have the people that are involved in these collaborative programs meeting, every couple of weeks to come together and see what's working, what's not working, how can we improve. We have tip sheets that have algorithms on them. They have the CPT codes on them that we're giving out to the practices. Myself, I'm doing chart reviews, working on the predictive modeling for CKD, that these measures do overlap frequently with which labs we're ordering, and we're seeing and making sure that these measures are being met and that there's compliance. Our diabetic coordinator works on putting out a educational flyer every month that has EMR suggestions on smart phrases to make sure that these lab results are being pulled into the patient's record, that she's available if there's any questions on getting CGMs ordered and covered by insurance, all of these things. So I think it's really education and it's support for the practices. That I think that's what it comes down to.
And in these, so great things that all of you are doing. And do you also involve ever patient advocates on some of your teams, or not? It's more just within the practice and the folks working. Yeah. No, that makes sense. Yeah. Super. Does anybody have any final questions before we go ahead and wrap up? All right. So great job to the panelists, and thank you so much.
Oh. I just really want to appreciate Dr. Wright for coming to join us today. That you're a wonderful facilitator. And again, to appreciate the panelists and our speakers from earlier this morning. I think it's just I don't know anything about 4-day windows at all. I just really appreciate all of the people in the room that do the hard work behind the scenes that for the doctors were like, well, that sounds boring. And it's really important to make sure that we get credit for the work that we're doing. I think it also means that the solutions that we need to solve medical problems are here in the room with folks who understand the behind the scenes network and framework that support the medical care we do. And we need to build this in for all of the physicians and practices around the state. So that's what we're going to be asking you to do next. If you open up your folder, you're going to see a sheet that looks like this, driver diagram. Go ahead and pull that out, and that's going to be our next task for the next half hour. We got all the heavy lifting and talking in before lunch, so now after lunch we're trying to do something more interactive. We already kind of went through drivers, so I feel like you heard before lunch from our information from our practices, a lot of the different problems, right? What are the drivers of poor uACR testing rates? We heard about barriers. We heard about patient-focused barriers. We heard about some ideas for change, things that your practices already told us. We've got an idea that we think we might need to focus on, and some things focused on the patients. And some of these we've talked about being outside the specific locus of control of a practice, of a provider organization, physician organization, things we need to advocate for as a lab, and then with our insurance stakeholders. And so now we want you to focus on the back of that sheet. So I'm going to ask you to flip to the back. That's a PDSA cycle. And these are some slides from when we used this sheet a couple of years ago with our regional meetings. That come from the Institute for Healthcare Improvement in the model of improvement, which asks us, what are we trying to accomplish? How will we know that that change is an improvement, and what change can we make that will result in an improvement? And so you've already heard a little bit about some drivers and reasons that we think things are not at goal. And so now we're thinking about, what are we going to change, and how are we going to decide if that change makes a difference? And all of you are expert in doing this. So what I'm going to do is ask you to think and reflect on all of the different information you've heard about urine albumin creatinine testing and GFR testing, and then come up with an idea for a PDSA cycle and work through the back of this worksheet. Usually we think of those biggest drivers as the things we want to change. In other words, there's 20 different things you've heard about today that we could change, and not all of them are going to lead to the same improvement. So thinking about your practices or POs, maybe one practice that you have in mind, what's the one thing that you might focus on that you think is going to actually lead to the biggest improvement in uACR testing rates? And so the idea would be to think of that item and just write out or sketch out on that worksheet following the instructions. How would you plan it? Who would be on the team? What would you do, and what would you measure? So I know we're not going to do this in the 30 minutes that we have, but I'm going to let you take some time, work through the worksheet, and then I'm going to ask a couple of people to report on what they chose and how they might measure it. What questions do people have about the task? As you start, raise your hand if you have questions, or if you need a worksheet. If you need a pen, raise your hand and we'll give you one. Okay, so take about 15 minutes and then I'll bring us back together. All right, I'm going to bring us all back together and ask, is there any brave person who would be willing to share their idea for a PDSA cycle? That's a good way to get everyone's attention. Anyone willing to share what you talked about with your table, what you picked as an idea for a PDSA cycle? Yes, thank you for being my volunteer.
Just to keep things moving along, I don't think your idea is all that. Can you shut those off? Thank you. So I don't know if our idea is all that super. So the primary drivers that we were focusing on was provider knowledge. We are thinking that perhaps maybe the EMR is not making it super intuitive for providers, and things of that nature. So we went back to the planned visit idea, because we're not sure if the providers are using, that heat map, or if, they're really, they might be ordering the test, and then depending on the lab to drop the code and things like that. So our plan would be to update the diabetic plan visit to include the KED measure. We would be using data from MDC and or from the year-end 2024 KED performance reports. We would know whether our test was an improvement by doing comparative data analysis, and we are predicting that the rates would improve and problems would be identified. But, for updating the planned visit, then of course we would be including the provider at minimum, like the clinical champion, if it were an MCT2D practice, the practice manager, and any other staff that would be involved in the process, to make sure everybody was aware of what the roles and responsibilities are and kind of make it a team approach.
So I think I hear a little bit about this being a change package. It's not just the order set or the visit organization that you're giving the provider or physician at the time of the visit, but there's also an educational piece built in. Did someone pick something totally different that they're willing to share?
So my name's Shannon Hill. I'm a quality coordinator at GMP Network. So one of the things that our PO does already is we own a retina view machine. So I outreach practices to get them on their patients, to get them on the schedule and come in and do the eye exams for them generally once a month. So my history before working for GMPN was clinical side. I'm a certified medical assistant, certified phlebotomist. And so my thing that we're trying to implement in our practices is a diabetes day. So instead of me just doing the eye exams, those patients who also come in and don't have their A1C, we've got a portable A1C machine drawing their blood for the eGFR and also having them urinate in a cup for the uACR.
Said plainly. But I think this idea of not waiting for them to go to an offsite lab and incorporating it and bundling it with for those of you who read the James Clear book, habit stacking, like you're already doing one thing and then add this thing to something you're already doing. That's amazing. Anyone else willing to pick something totally different?
Hi, I'm Caitlin. I'm at Michigan Medicine and one of the clinical champion PO. And we have a system that is just not being used, we've discovered today. So we have what's called a best practice advisory in Epic. And if we already have the clinical decision making for like the MAs. So if the patient's they're due for a urine albumin creatinine ratio, the MA can draw the urine and order the lab. And most of our labs or clinics have a lab either in the building or they'll get the urine picked up later that day. But it just hasn't been done because I think a lot of MA turnover, staffing issues. So our plan was to meet with each clinic manager, remind them of the process, and also let each clinic know for the providers that this will be happening. And then potentially, if this isn't increasing our percentage, we can run the gap list with like a care manager of some kind. But I had totally forgotten this. Since I've been there, we've never done this process, but it exists. Someone already did it.
Yeah. Quality improvement projects of times past. They have been done, and then go to the QI graveyard until you need them again. Any other ideas that you think are important to share that kind of cover a different aspect of the drivers, a different part of the process? Anyone else with something to add?
When you think about the different labs that are required and medical necessity and the timing of those labs, if you have patients that are being seen by a specialist, they may be ordering and getting results and not sharing it back with a PCP. And that's where like a registry, like Health Focus, is very important. Communicate and give visibility as to what those values are, so that we can close gaps in care, because sometimes specialists don't code the right things either.
Yeah, so this idea, for our claims, I think we will be getting data into the MCT2D dashboard if it's done by anybody. even if it was a specialist that's not in your primary care practice, so potentially not getting credit. And I think there may be a piece with partnering because our nephrologists are also working on this measure. Maybe the nephrologists that you work with aren't part of the MCT2D program, but maybe an opportunity to partner with them to perhaps they have a urine test. Dr. Wright tells me that every person who goes to a nephrologist's office gets a urine test, but they just do it for everyone. So maybe there's an opportunity for some of your patients. Anything else to add? Any questions before I move us on to our last presentation of the day? Again, I just really appreciate all of the ideas in the room, and we've been listening. There are some things I think, maybe we come up with a 5 or 10 minute educational video for physicians, providers, different team members explaining this. Some other things that we might do as a collaborative to help you. You can keep your diagram. If there are any specific things that you thought about as you get ready to listen to this last presentation and you're filling out your evaluation, not now, but after the last presentation, if you want to email us or share with us things that you've thought about today that we could do to help you, please do share those with us as they're top of mind. As I transition us though to our last presentation of the day, I pressed the screen and I'm not supposed to do that, but nothing bad happened except that I think I've lost, oh no, I didn't, I put it here. This is my life, right? Losing your glasses because they're on the top of your head. I'm not entirely sure that that is working. Did I broke it? Did I break it? Oh, I did. I touched it and it broke. That's great. Okay, so when I press the button again, I think Felicia will start talking, but I want to introduce her. I'm so excited to introduce our next speakers. This last hour is going to be spent talking about how we drive health equity through data. So as all of you know, bringing our patient's voice front and center is so important to what we do. And so before I introduce our next speakers, I want to introduce Felicia. Felicia is a member of our patient advisory board. She has spent 30 years working as an administrator in the healthcare industry. She's retired now. She says that she's an aspiring writer, a mental health advocate, and a good, proud auntie. So we asked her to share from her perspective as a patient, what does it mean to experience health challenges? And how did you experience that interacting with your identity? And in this case, talking about perceived race, ethnicity, and background. And so I'll let Felicia tell you her story. So I just want to first appreciate Felicia for sharing her story. And then the other person you saw, the excellent listener, is Noah. And Noah is one of our design team specialists. And they just have a real magic, I think, about bringing out stories from our patients. So that few minutes took a lot of time editing down. But I think as I listened to Felicia's story and her willingness to share her experiences and how she's navigated her identity, and then experience self-advocacy. I think we all do this, but we know for our patients who are minoritized in the world that this is more commonly something that our patients navigate, with having to self-advocate and find someone who's going to be a good listener and a good physician for you. And then I just want to name that it can be really difficult for us as leaders to engage in discussions about race, ethnicity, and racism. But when I think about the experiences of our patients, the real experience that our patients have, and grounding us in this work, I think it makes it really feel real to me. And so I think appreciating Felicia's nuanced and expansive view of all patients, right, including those who have faced pain, is really, really important. So I'm going to move on and introduce our next presenters, our guests for today. Oh, I touched the keyboard again, Jake. Like I just can't help myself touching the keyboard. Don't touch the keyboard. It's going to, no one's going home. Sorry about that. Okay, let's try again. That's okay. All right, we're gonna go back through Felicia. Okay, to you. I'm gonna have you both introduce yourselves and decide whether you'd like to hold the mic or use the mic here, and please don't touch the keyboard.
Okay. Hi, everyone. I'm Selena Tran. I am the health data analyst at MShield, and I'm really excited to be here.
And I'm Matthias Kirsch. I am the health informatics specialist with MShield.
And we're here to talk to you about health equity and data and quality improvement. Cool. So before we dive in, I'd like to take a moment just to give you an overview of what we'll be covering today. First, we'll start with the why this work matters, and especially when it comes to linking health equity and data. And this will really set the stage for the time that we'll be spending together. And then next, we'll take a moment to align on key terms and definitions, and having shared language ensures that we're all on the same page and that we are in consensus with one another when talking about health equity and data. And then after that, Matthias and I will turn it over to Dr. Ashman to give you an example from diabetes care, and also to go over the race and ethnicity data at MCT2D. And there'll be time for an activity, and then we'll come back together for an open dialogue and to reflect together. And finally, we'll wrap up with a Q&A session. So during this time, please feel free to jot down any questions that you have along the way. Okay, so by the end of the presentation, our goal is that you'll carry forth the following takeaways, right? So first, I just want to lay the groundwork that health outcomes are heterogeneous, right? Some groups experience worse outcomes than others. And as such, like focusing on high quality care for all patients means understanding which groups may be experiencing different outcomes. And one way to understand how people experience care is through updating the collection and use of race and ethnicity data. And so throughout our discussion today, we want you to feel empowered to continue doing the work that you are currently doing wherever you may be in the process, and that the best place to start is where you are now and to continue building from there. And we just also want to re-emphasize that the work that you're doing is very important and to not lose sight of that. Oh, that way. Okay. So I'm going to start off by talking about why we're here today and the impact of data collection and conducting analyses and the importance of collecting more specific demographic data. So CQIs have been leading the nation in achieving the triple aim of, one, improving patient care, two, lowering cost, and the third of improving health. However, we've already achieved the big initial easy wins, such as reducing the use of less effective and costly surgical hardware. And so for the next phase of quality improvement, we need to first understand what is the lesser known sort of things that are affecting quality care. And we're about halfway through 2020-25, right? And Blue Cross Blue Shield of Michigan continues to support the work that we're all doing and urges us to proceed with how we have been doing. And so one way to continue with the quality improvement efforts is to look into the data that we have. And so that brings us to taking a deeper look into the data that we have. And you can see here that there is an apparent upward trajectory of quality improvements to date. But if you're looking at the lower and the upper bounds of this trend line, we see that there are inequities that are driving poor quality outcomes for certain groups that are not being shown because of how the data is being presented. And as you may know from your own personal experiences, that there are patients who don't have the high quality outcomes, and this may be due to a myriad of social factors. And so today we're talking about race and ethnicity data in the data that we have, right? And to illustrate the importance of looking at race and ethnicity data, I want to bring you this example of what happens when we don't disaggregate our data by race and ethnicity. And so in the graph depicted here, what we see is that over the span of 2 decades, looking at all of the patients when we don't disaggregate by race and ethnicity, it looks like the adverse outcomes are declining. And that's great, right? Because that means that quality improvement is improving for all. But what happens when we don't disaggregate data by race and ethnicity is that we just kind of assume that it's all patients who are improving, where we may be missing those subtle groups, right? And then when we actually do disaggregate, there's a different story that's being told. We see more of that heterogeneity in the outcomes that was being showed by the upper and lower bounds, right? Here, when we disaggregate by race and ethnicity, we see 2 different groups. One that is definitely clearly improving with the adverse outcome trend line decreasing. And there's one that is not necessarily improving. And this demonstrates the importance of why we need to look at race and ethnicity and disaggregating the data, because we don't know what we may be missing when we are including all of the patients together without looking at all of these different social factors, right? And so to continue to move the needle on quality improvement, we need to have a more nuanced approach to the data that we collect and how we analyze it, and then using that data to inform the decisions towards the care.
So to kind of ground us here, we wanted to talk about the language that we use when we talk about health equity. So the first one is social drivers of health, which you've probably have all heard about. The social drivers of health are the conditions in which people live, work, play, and that includes a lot of different factors like food, housing, transportation, education, income, and safety. We know that these can be responsible for major differences in health outcomes across populations, such as morbidity, mortality, and life expectancy. So these SDOH are the broader systems that shape socioeconomic conditions. We know also that these can be really connected to race and ethnicity. So when we think about race and ethnicity, we're not talking about necessarily a biological difference between people. What we're talking about is a socio-political category. These are the way people are perceived within the world, the communities, and the spaces that people occupy, the way that identity can mark different groups of people. But when we use data about race and ethnicity in analyses, there are this whole spectrum of things that it can kind of be a proxy for. And you've probably seen this. You've seen this in studies, you've seen this in news articles. We just need to be really mindful that when we are using this, this doesn't mean that a particular group of people just has worse health or worse biology. It means that there's a whole range of things that could be going on. So let's talk about racism, which is not something that people want to talk about much right now. Right? This is an uncomfortable topic. People politically are all over the place about this. So at MShield, where we're really about health equity, we wanted to talk about racism in a way that is really bringing up what we're actually doing here. So if you look at this middle section, what we really are talking about is that we want to address policies that are set up to keep some people oppressed, or policies or structures, societal things that keep some people from having high quality care, or inconsistent distribution of treatments and practices. So we wanted to kind of give some examples of different ways of talking about this, where we're really emphasizing that all people should have access to high quality care. So when we think about all the different areas that can be affected by racism, this is what we call systemic racism. So, you see on here over under the individual, this interpersonal. I think this is what most people think about, like, you're a racist, you have said racist things. But what we know is that there's actually this whole history of things that have been set up in our country and in the world, on a structural, institutional, state, national, organizational level that affect people based on their race and ethnicity. And so these are the areas that we can actually address and make sure that we have policies in place that allow everyone to have access. So again, if we're thinking about wanting to give everyone access to the best healthcare possible, what anti-racism is really about the practice of actively identifying and addressing these things, which means changing policies, changing behaviors, and changing beliefs that sustain racial inequities. So when we think about reframing this and not necessarily using the word race or racism, we're addressing widespread gaps in access and quality of care, or we're identifying and addressing the root causes of poor access and quality. And I think these are things that all people can agree on. We want to make sure if there's a barrier keeping someone from high quality care, let's address it and let's make sure we can provide them the best care possible. So one of the roles of MShield has been to kind of keep people informed of how things are changing. And one of the things that's recently changed is the way that race and ethnicity data has been collected. And this kind of got started in a federal way. So we've put out a couple of different guides about how to think about collecting race and ethnicity. And it basically comes down to this. So we know that there is a lot of variability about the way that data is collected across Michigan and across the country, which can really lead to difficulty when we're trying to do analysis of data breaking down by different groups. So the idea is to have a single way that everyone is doing this across the state. And let's see. Yeah, so there's been requirements to collect data from the national point of view, but not like a systemic way to do it. So this is what we're trying to work on. We wanted to be able to identify areas of focus by having a similar definition for everyone, and then be able to measure the effectiveness of our quality improvement against these new measures. So the updated guidance from the Office of Management and Budget calls for using a single item to collect race and ethnicity data. And this is a little different from the way it used to be, which had race and ethnicity as two different questions. So as you'll see, Hispanic and Latino are captured as one item under here. It also adds Middle Eastern or North African as a category. And it allows people to select more than one option based on the way that they identify. The other things that we really emphasize are that people need to be able to self-report. So as much as possible, allowing patients to fill out the forms themselves or to at least review information that's collected on them and make sure that that is correct. Let's see. Yep. We also, when we're asking the people the questions, instead of just writing other here, we said, prefer to self-identify, because people can identify as many different things. And if some people want to write that in, that should be allowed. Okay, so how has this been implemented? So we have worked with our P4P task force and Blue Cross Blue Shield to be part of the HIE component for the 2025 P4P. This is currently just an extra credit for hospitals, but it's going to become, in 2026, we're hoping it'll be part of the full VBR so that more places will be collecting this data in a streamlined way. All right, so to kind of wrap up our section, we're going to have some new data on race and ethnicity. And I think there's a lot of questions about what exactly do you do once you have this data? So we just have a couple of basic data pitfalls and different ways to think about how to deal with data. So one thing that often happens in analysis is using white, non-Hispanic as a default category. We're saying that maybe isn't always the best idea, because comparing to an overall population average, or even better, like to a goal value. So if you have a value of A1C, for instance, that you'd like, or a percentage of population who want to be below a certain level, that's what you should be comparing to, not to another racial and ethnic group. Also collapsing small groups. So this often happens. You have a population in Michigan where, we might only have 1 or 2% of the population who identifies a certain way, but collapsing all those groups into a single other group doesn't really give you very much information. So as much as possible, disaggregating data. It's one of those things you're just going to have to talk about, that you have limited data because of the size of the population, but you could find some really different outcomes for different groups. The other thing, the reason that we're allowing people to multi-select instead of just saying multiracial is that identities, whether they are one part of someone's identity or that their whole identity, can still play a factor. So instead of just collapsing, again, everyone into a multiracial, using those individual identities in a non-mutually exclusive way. And then, as I mentioned before, trying not to use race, ethnicity, or geographic origin as proxies for genetic ancestry or biology. We have a lot of really sophisticated tests for testing genetic background, and those should be used in place of something like race or ethnicity. So now I'm going to turn it over to Lauren to take us through the next sections.
We appreciate that general introduction, and more specifically just to appreciate how MShield is helping all of our CQIs understand best practices and be consistent, right, across our hospital and our population health CQIs with what we're doing. But I did want to kind of share a specific example about diabetes care that I thought was instructive because the data comes from federally qualified health centers that have something in common with the way that we're collecting data into the MCT2D data registry. So this study was done in 275 clinics. That's a lot of clinics, but all affiliated with the same network of FQHCs and all using the same data registry, pretty similarly to how we do, right? Data is collected at the site of the clinic and then aggregated to kind of make improvements across a collaborative. And the question that they were asking was about CGMs. What are the patterns of CGM prescribing in this underserved population by definition? Because that is really what FQHCs are designed to do. And then looking at different variables that are associated with different patterns of CGM prescribing. And so when you write a research paper, you describe your population in a table. And so they described the characteristics of patients that were in their analysis. They actually looked at type 1 and type 2. So I'm just disaggregating the type 2 diabetes information because I thought it might be more interesting here today. And so looking at the patients who have a CGM prescription versus no CGM prescription, we see some differences here. We see no difference by age from the mean. We do see a difference, although that p-value kind of tells you it's like marginal, between people identifying as Black and identifying as white. And then we have this other category, which I'll talk about next. And looking at ethnicity. And so we see pretty big differences, 78% versus 21% in the population prescribed CGMs for this self-reported ethnicity. No difference between men and women, although I think in my practice, I do see some differences in who is willing to uptake CGMs. Some of it has to do with whether the person brought their significant other with them to the office visit. And then interesting differences with insurance statuses. So even in a FQHC population, we take care of people who have private insurance and we're in their neighborhood and it's where they prefer to get care. But we can really appreciate that in this population, the rates of prescribing are higher CGM prescription for patients with Medicaid and much, much lower for patients with no health insurance. That makes sense to me, right? Patients with health insurance are much less likely to be able to access this technology. And so then statistical analyses, and this is what we do, our wonderful data team at MCT2D with all this massive amount of data that you're feeding us, we're able to start to look at patterns across the collaborative where for any one practice, we really don't have the volume of patients to make analyses and associations. And what we appreciate is participants with higher versus lower odds of getting that prescription for CGM. And the thing that I will say is this doesn't say if they got it, doesn't say if they wore it, just was it prescribed or not. And so we can see, compared to the mean, lower odds for people who identified Black race or other race versus white being the referent here. And similarly, much lower for people identifying as Hispanic ethnicity. And then here we see the, actually I was wrong about private, sorry about that. Private being the referent, about the same for Medicaid, less for Medicare. And this data went from 2014 to 2022. So most of it was before some of the changes in Medicare policy, and then much, much less for uninsured. But interestingly, when you look at the odds, right, you see that having Hispanic ethnicity is about the same as being uninsured in terms of the effect that it has on your likelihood to receive a prescription. So our job is to decide what we want to do with data like this. What can we do as a collaborative? What can we do at the physician organization? And what can we do as a practice to help individuals who may not be achieving the same benefit from diabetes technologies as others? And here's where I raise the points I think that Selena and Matthias already raised in terms of pitfalls in data analysis. So why is white, not Hispanic, the reference point? Why are we using a certain racial category rather than another? And I love the idea of what is our goal? What is our average for the quality improvement collaborative and who is getting to that goal or not? Who decides the assignment of race and ethnicity in the EHR? And so reading this article, they never wrote down, was this being from a paper form? Was this something that patients did in the EHR? When you call at Michigan Medicine, where I work, as a new patient, you talk to an individual and they read out this list of like 80 different races and ethnicities, or ask you, what do you want me to put? So there's not a whole lot of accuracy there. So they didn't report that. And then how do we move from naming it to addressing it? How do we move from just saying this exists to what we might be able to do to improve? This article had editorial prescribed along with this, and I think the summary here is pretty good, which is that the question of how to achieve equity remains really complicated. There are a lot of system level factors that need to be identified. There's a lot of disparities at several steps in the process, not only prescribing, that need to be identified. And this could be a reflection just of biased clinician behavior, but more likely it may refer to differences in access, diabetes education, different support, and lack of support for us as clinicians. And so each of these we can address, and we'll know we're improving when we see the data improve. And so I think this is just interesting because it gives us an example, I think, of what others are doing, and then applying this framework for understanding how these processes are affecting our patients. These are the processes that might be affecting our patients with diabetes technology, which could be just the neighborhood that someone lives in, climate-induced events, access to some of the lifestyle changes that we want patients to do. So I want to move the conversation to what you're doing and really ground this in the work that we do. And just to name that Michigan is very heterogeneous. And when we think about the different race and ethnicity groups in Michigan, for some of your practices, it's patients originally from different Asian countries speaking Cantonese, and we don't have any patient education materials in that language. It may be different immigrant populations from different areas in the world. And so I think we can't really name what those disparities are for you. You all know that from the practices that you work with. But we did want to ask you about the way that you're collecting data and just make sure at baseline we're collecting this information correctly. So we asked you this information in the survey that you filled out prior to coming to the meeting today. And I wanted to share what you told us about the way that you're collecting data. So the first question that we ask is, how complete do you feel like the data is from your practices on race and ethnicity? And I think we're doing pretty well, right? So many of you suggested that the data is between 50 and 100% complete, but there are still some areas that are not doing well, and some of us who are unsure, which is understandable. And then the next question is, how accurate are we? And so I think we'd all like for this to move over so that we can all agree that our data is very accurate, but again, areas for improvement. And then finally, how are you using the data? And I think this is really where we get to the discussion piece of this last presentation for the day, which is moving from identifying to doing something about it, right? Using a dashboard to understand how we can make change. And very few of us have those actionable ways to work our data to see how we could improve. So here are some of the written responses you gave us that were interfaced with multiple EHRs. We do have a registry available. One of your practices at least are using a quality metric focused on blood pressure that does disaggregate to look at populations that may not be faring as well. One of you is working on a process with SDOH reporting. And then one of you says, we have a demographics quality dashboard where we can look at these metrics, and we've used it to look at disparities. So I think a wide variety, but a lot of best practices that we can learn from those of you who are doing it well. So you may ask, where is the race and why is our data not on here? Because we don't have it yet. So I think thinking about presenting this very preliminary information starting in Q3 of 2025, we're hoping to start collecting that data. And what I really want to know from you is, what should we be doing with it? What do you suggest that we do to use this data to improve? We're not going to add this to the dashboard at first. We're going to use it more internally to look more at an aggregate level of the collaborative, just so that we're crystal clear on where the data is coming from. It's coming from your ADT feed that you're sharing with MyHIN, derived from your EHR variety data rather, and that what we're doing is mapping that data to the recommended categories from NShields, but there are 90 categories that need to be mapped. I think I'm pretty excited about the data completeness, though, that we have a response for 80% of the patient population. So that's pretty exciting to start with. And again, this idea of mapping all of the information and data to these categories. We asked you at our last collaborative wide meeting, what did you want what does she want this to look like? And some of you wrote bar charts, some of you wrote pie charts, but we do have some ideas that we've shared from our prior work with you to look at how different POs are managing different populations, how we're doing screening in different rates by race and ethnicity and other variables, and then looking at some of our outcome data and our pillars. And so this is what we're proposing to start and where I'd like your feedback. We're proposing to start at an aggregate level and really focused on the quality improvement things we're already doing. So staying aligned, let's take a look at the uACR measure and let's take a look at whether the data vary at all. It's a great use case for us to understand. And then that we plan to provide you some detailed reports, just taking a look at this so we can get some feedback from you about how this is helpful. So this is what an example report might look at. This isn't an actual report yet. This is our mock-up. And so we might show you in your PO what a breakdown of reported race and ethnicity is. I think we'll probably not use other. We'll probably ask MShield for help on how to report that. And then we might look at screening rates to identify where screening rates are different. And you can see this little star, like looking at areas that are quite different. So I'm going to break us up into groups. We've done large group, small group, work on your own. Now we're going to talk at tables. And what I'd like to do is to ask folks, there should be a blue piece of paper on your table somewhere. To find that piece of paper, if you're the lucky person holding the blue piece of paper, give it to someone else. They're going to have to report out. What we've done is given you some discussion questions, and I'd like you to identify one person to lead the discussion and start with the question that has a sticker next to it, because I'm going to ask different groups to report out on different stickers. I'm going to let you discuss for 5 or 10 minutes and we'll bring it back together. All right, I am going to wrap us up and then ask for tables 1, 2, and 3 to report out first. So the sticker on your blue sheet corresponds to the question that I'd like you to report out on. So maybe we'll go with table 2 to tell us about, is your PO already addressing disparities? And what are you doing to address them? So who's going to report out for table 2? All right, table 2 reporter, please tell me your name and your PO.
Alex Tracy with GMP Network and LPO. So we had question 1, what is your PO already addressing disparities in quality metrics for other payers and programs, and what are you doing to address it? The first thing we are doing to address it is just collecting data. We're still working very hard to get consistent data. Even with the new patient paperwork, there's a 50-50 shot that the patient fills it out. There's only a 50-50 shot from there that staff enters it. So when you're working with 25% of your data, you can't make good decisions. And so we're discussing ways to educate the providers and the front staff in order to better collect data so that we can, at some point, have enough data to actually have any kind of meaningful outcome to it.
Starting with data collection is always the most important thing, because if you don't have good data, then what's the point of improving on it? And allowing patients the opportunity, right? If they don't want to report, that's totally okay, but making it accessible to them. I'm going to ask table 3 to report out on the same question. Question 1.
We had quite a heated conversation over here. I think, is the PO already addressing disparities in the quality metrics? I think we're all starting to, but where we're struggling is the same thing as you guys is the data accurate? How deep can we go? In our EMR in particular, this has been a field, but it's a field that also is required to create a chart. And so the likelihood that I picked the path of least resistance and said unknown or other is really high. And then I think the other thing that we kind of discussed too is who's race are we using? If the patient's reporting this when they sign up for a health plan, are we using that? Are we using the data that they gave me where maybe they show up and how often are we asking? Maybe they showed up today and they decided to be a different race than they were last time. I think you can get a variety of experiences with the different patients. And so I think we're in the same space where we're starting to, but I think we have some underlying things to be addressed first.
Raise this question of someone making a change is almost a joke, but I don't think it is, because our understanding of even the options that we give people have changed. For example, including North African as a separate disaggregated race from white. So I think it makes perfect sense to think about obtaining and then improving our data. I'm going to ask the same question, the first question for table 1 to report out.
Yeah, so for that question for us, we have a couple of POs here at our table, and at the moment we haven't really been doing anything to address the disparities with the quality metrics from other payers or programs or anything like that. So it's still pretty new to us.
In change management and motivational interviewing, we talk about, like, if you're starting at 0, you just say, congratulations, you're at the first step. So I think identifying where we are lets us improve. I'm going to move on to tables 4, 5, and 6 to the second question. How do we go from identifying a disparity to addressing it? I've gone through no man's land. I think it's that screen that's making the microphone unhappy. So table 6, would you please report out on the second question, identifying to addressing?
I think you gave us the hard question. Yeah, not so sure about that. So our 3 groups, I mean, we are identifying disparities, but we're not yet moving to the next step. We're doing social determinants of health. We all feel like we're doing that pretty well, but then not linking that with race and ethnicity. We did talk a little bit. We have one PO. Now we're getting the kickback. One PO that is doing some mobile mammogram to areas that's based on social needs and maybe starting to use some ethnicity, race in order to identify where that would go. So that would be an example of something that they could do. But the bottom line is addressing the data. It's a manual process frequently, or EMRs are challenged, or there's too many choices, or like MCCO, we are primarily a white community. There's not a lot of variability in an epic. That you like that example, you can pick 80 different things. And so you've got white as a huge category and everything else is 1 or 2 patients. So it's really hard to figure out.
I just want to name that a racial disparity may not be the disparity that affects a community. It may be a rurality. And so I think we all should feel like we know our communities best, and that there may be areas where we really clearly see a barrier for a certain population, maybe Medicare populations or populations with low income, and that's what we decide to focus on. Table 5, hopefully the same question with less feedback.
All right, so we are Lakeland Care and Medical Network 1 with question number 2. So if we have already identified a disparity, whatever that might be, we felt like maybe it could be a good idea to use our care managers and community health workers to engage with that identified population and that specific disparity in that area, and providing education, support, and maybe specifically resources to assist with that disparity. And I think that, like, for our group, we have the care managers have like a teams group together, and they know each other, and they are able to, access the resources. And then if they don't know the answer, they can easily just say, hey, I have a patient who is in this area and has transportation issues. And then somebody can jump in and say, this is the program that you want to get them connected with.
Idea of looking at neighborhoods and communities has been a area I think that a lot of us have focused on as a good area of improvement. I'm looking at time. I'm going to move on to table 7 with what resources do you have available to address any disparities?
I think we have the resources, we have the data, we have the analytic tools. What we don't have are the staff and the time. And this is one more priority out of all our priorities. And it's just not a driver in our face.
That we may need to de-implement something if we want to add something in. And as MCT2D, we don't want to ask you to add something if we're not adding new resources. That's so important. So that leads very nicely to the last question. I'm going to go over to table 10. What support do you need in addressing these disparities that MCT2D can provide?
Hello, our table is United Physicians and HVPA, and I think MShield was really important at this presentation today in that we need to centralize the options. I think you mentioned at Michigan, it's sort of 80 options, and you might go somewhere else where it's 5, so you answer them differently. So just kind of making sure that the data across the board is similar. That's really the only way we would have integrity.
So at MCT2D, we can help by making sure that we standardize where it can be the options, at least for selecting race and ethnicity data. So from here, I just want to wrap us up and be cognizant of time. And we have one more poll. And this has to do with your preferences about counting data when someone chooses more than one category. So if you can find your electronic device again, you should already be joined to the poll. And Jackie, will it magically work? Can people just type in A or B? Okay, magic or technology. So you can either select A. Would you like us to assign them to the least common selection that they make? So I think that means for us, if there's like a certain number of patients in each category, assigned to the least likely to make that one more robust, or to count them more than once under each race and ethnicity category that they choose from a list. So if you go to your phone, you should be in this poll if you answered the prior one. Either, if not, you can send MCT2D 945 to the phone number 2233, and then you should be able to just type in A or B. And then I think I have to go to the next. Oh, it worked. It worked. Great. I can't see how many people have answered, but I can see that 72% of you, a majority, recommended B. That's really helpful to us. It helps us with the next step that we're taking. All right, I think we did it. So that was our discussion and debrief and key takeaways. The best place to start is where you are. I'll leave that one for us today. And then I do want to ask that everyone fill out the evaluation, which is paper. We don't have to use the QR code. And I just want to appreciate all of our guest speakers today, including the team from MShield, and ask you to fill out your evaluation as you leave. And then I just want to say sincerely, this has been a difficult presentation to prepare for and to think about bringing up, what I think is a sensitive and difficult topic to you. Grounding it in the voices of our patients and the work that you're doing is so important. And I just really appreciate, I think, Laria, I'll quote you, you said the vibe is good in this room. Thank you for bringing a good vibe and bringing all your energy to our collaborative. So with that, I'll say goodbye.